So it is now more than urgent to create a momentum for blood safety and availability and encourage WHO member states to render their blood services more resilient and efficient. Now, I would like to invite Mr. Panos Englesos, TIF's president and founding member, for his welcome address. Now, whatever I say for this man, it will be not enough. I'd just like to stress that he is a graduate of London University in Economics and Accounting and a renowned business person in Cyprus. He is considered, and he is actually, the founding father of the international thalassemia community. And for his work, he has received several awards because of his pioneer role and work in the fight against thalassemia in Cyprus and the world, such as the District Governor's Appreciation by Lions International Gold Medal for continuous and long-term services in fighting for patients with thalassemia. In 1982, and the King Abdulaziz University Award for contribution in establishing Thalassemia Association, Saudi Arabia in 1993, among others. Please, Panos, your presentation, please. University Award for contribution in establishing Thalassemia Association, Saudi Arabia in 1993.
Ladies and gentlemen, on behalf of the board of the directors of the Thalassemia International Federation, it is a great honor and pleasure to welcome you to the first meeting of the Global Forum on Access to Safe Blood Products for Patients in Need of Regular Transfusions. This patient-led initiative is organized in the context of TIF's official relations with the WHO and aims to shed light onto blood safety and availability issues across the world, promoting the development and synergies between all relevant stakeholders and address them. The importance of blood transfusion for patients with thalassemia and other hemoglobin disorders cannot be stressed enough. Safe and adequate blood means life. For this vulnerable group, and the ongoing COVID-19 pandemic has indeed brought to the forefront the need to further strengthen national health systems, including national blood establishments that are based on the principles of universal coverage and patient-centeredness, and very importantly, to support voluntary non-remunerated blood donations practice. Today, this first meeting of the Global Forum of Transfusion-Dependent Patients builds on the findings on the Global Thalassemia Review 2021 that was developed to assess the very existence and quality of services provided to patients with thalassemia across the world, and in particular in countries with medium and high disease prevalence. The findings of the review have been revealing. National programs for the prevention of thalassemia are largely absent. In low and middle income countries, 75% of the patients do not have access to regular blood transfusion. Iron load monitoring and multidisciplinary care are either suboptimal or completely absent. 9% of the patients must assort out-of-pocket expenses to have access to basic healthcare services. We thus may safely state that there is profound heterogeneity and inequality between thalassemia patients across the world, and that the time of global action is now, as the rights as patients and humans for decent and quality health and other care services are largely violated. We are grateful to the World Health Organization for guiding countries through handles and supporting the improvement and accessibility of healthcare services, including blood safety and availability. We are thankful for our long and close collaboration that has indeed contributed to improve policies through which thousands of lives of patients have been saved throughout the years. The active participation of the WHO in today's meeting is yet another proof of its painstaking effort to strengthen health systems. We hope that the Global Forum will further enhance the awareness and sensitization of governments in acknowledging the many and complex aimed needs in transfusion practice, in listening to the patient's voice, and in involving them in decision-making process. Therefore, along with our appreciation to the World Health Organization, we must express our gratefulness to the International Society of Blood Transfusion for instantly working to promote the education of blood transfusion specialists and to the leading experts from Greece, France, and UK who accepted our invitation and agreed to share with us today their knowledge and experiences. We hope that the global blood ecosystem, including bodies such as the European Commission, the Council of Europe, the European Blood Alliance, the European Hematology Association, the American Society of Hematology, the Centers for Disease Control and Prevention, the European Center for Disease Prevention and Control, amongst others, will embrace our effort and contribute to policy improvements at national level and to the adoption of WHO guidelines on blood safety and availability. We need a concerted effort to give transfusion-dependent patients an equal chance for life. We wish that the patient healthcare professionals, researchers, and policymakers will join forces and make today's effort a success. Thank you all, and I look forward to the deliberations and conclusions of the work of this forum so as to support the work and effort of TIF towards moving forward to a call for action of promoting safety and adequacy of blood and its products. Thank you.
Very grateful for what you have done to support the clinical care of thalassemia patients. Tremendous work. We are very grateful to you and thank you for the support for all professionals working in the field. And now I have the great pleasure to invite Dr. Susanna Jacob, the Director General of the World Health Organization, to address the global thalassemia community. Susanna, allow me to call you Susanna, is a native of Hungary, and she has held a number of high-profile national and international public health policy positions in the last 3 decades, including as the founding director of the ECDC, the European Center for Disease Control and Prevention in Stockholm, Sweden. Between 2005 and 2010, Susanna built the center into an internationally respected center of excellence in the fight against infectious diseases. You have the floor, please, Susanna. Thank you very much.
Good morning, good afternoon, and good evening, everyone. On behalf of Dr. Tedros, our Director General, and the World Health Organization, I am delighted to deliver opening remarks in this first global forum on access to safe blood products for patients in need of regular transfusion, conducted by the Thalassemia International Federation. There is no question that blood products, and blood therapies save lives. They save lives in many circumstances. Although most people might equate blood transfusion with accidents, traumatic injuries, and surgery, we must remember the wide range of conditions for which blood products are given, from postpartum hemorrhage to anemias and chronic disorders like sickle cell disease, thalassemia, and hemophilia, to deficiencies of the immune system and cancers. But the products we administer must be safe and quality assured, and they must be universally available and accessible. Most critically, we must improve the capacity of all countries to provide these. Our progress to date has been slow, especially in developing countries. In many countries, there are problems not only with the safety of blood, but also with supply. Blood collection is insufficient as a result of low levels of blood donation. Quality control measures are inadequate. Some countries do not have effective hemovigilance and pharmacovigilance systems. Some clinical practices are suboptimal. Policy, regulations, governance, and financing for national blood systems may be inadequate or entirely absent. It is therefore not surprising that patients in such countries have been put at risk, and health workers have been severely stressed by a lack of access to safe blood products. In response to these challenges, in May 2010, the World Health Assembly passed a resolution on the availability, safety, and quality of blood products. This resolution urged all member states to achieve self-sufficiency of quality blood and plasma programs and to put in place sustainable systems for safe and rational use by appropriately trained personnel. Many countries have found it difficult to achieve the goals set forth in the resolution. To help member states overcome the challenges they face in its implementation, WHO established in February 2020 the Action Framework to advance universal access to safe, effective, and quality-assured blood products 2020-2023. The Action Framework contains 6 strategic objectives and accompanying activities, outcomes, and outputs. Of these objectives, I would like to highlight one in particular: partnerships, collaboration, and information exchange to achieve key priorities and jointly address challenges and emerging threats at global, regional, and national levels. If there is anything we have learned from the current outbreak of coronavirus, which applies to all of WHO's work, it is the importance of collaboration and information exchange. This kind of global solidarity is absolutely critical to achieving a healthier, safer, and fairer world. I wish you a very productive meeting.
Thank you very, very much, Dr. Jacob, for this wonderful, excellent welcome address and your messages. Thank you very much. And now it is pleasure to invite Dr. Yoon to give a presentation and introduction, blood safety and availability, the work of the WHO over the years on a recurring global issue. Dr. Yoon is a team lead for blood and other products of human origin in the WHO, and she has served as the director of the Central Blood Transfusion Service at the Indonesian Red Cross for several years, and then the coordinator of the master's program on biomedics with specialty in transfusion science at the University of Indonesia, and the blood services program coordinator at the Directorate of Primary Health Services, Ministry of Health, Indonesia. Yoon, please. Thank you for joining us.
Thank you, Professor Politis, for the nice introduction. So I will try to share my screen. Yeah. I hope my slide is already on the screen.
Yes.
Okay. So good morning, good afternoon, good evening, everyone. It is my pleasure to be here in the important global forum conducted by the International Thalassemia Federation. So first of all, WHO also would like to congratulate ITF for conducting this important global forum. So in this occasion, we would like to share with you some information on the WHO work over the years on the recurring global issue on blood services. So I have no disclosure for this meeting. As mentioned by our DDG, that blood and blood components are critical for treatment of bleeding due to birth, delivery, severe injuries, and surgical procedures. Also for managing life-threatening conditions such as hemophilia, thalassemia, immune deficiency, and cancer. And moreover, the plasma-derived medicinal products such as albumin, blood coagulation factors, immunoglobulins, and others also important for managing certain medical conditions. So from the Global Database on Blood Safety 2018, we identified there are 6 main challenges in blood service. So the first challenge is inadequacy in policy, regulations, governance, and financing, in which the global data 2018 shows that only 72% of reporting countries has national blood policy, and only 64% has legislation on quality and safety of blood. Insufficient supply of blood products is another challenge, in which there are still 62 member states with blood donation rate less than 10 per 1,000 populations. Another challenge is deficiency in safety, effectiveness, and quality, in which the data again shows that only 80% of donated blood was tested in low to medium income countries. Lack of availability of PDMPs again is another challenge. The data shows that in low to medium income countries, only 37 to 69% blood collected separated into components, and only 50 out of 171 reporting countries produce PDMPs for their plasma. Other challenges are suboptimal clinical practices and poor access to blood during emergency situations. So this situation supported by the data that 128 out of 171 countries reporting have national guidelines on clinical use of blood, and only around 50% of hospitals have transfusion committee, and 49% of reporting countries has hemovigilance system in place. And again, only few countries has developed blood supply preparedness system. So what is the WHO response to these challenges in the past? As mentioned by our DDG, that there are some WHA resolutions being developed. So at least there are three resolutions, which is important. So one is the resolution on utilization and supply of human blood and blood products issued in 1975. Another resolution is on designation of 14 June as the World Blood Donor Day, issued in 2005. And the last resolution issued in 2010 is on availability, safety, and quality of blood products. And in response to these resolutions, WHO also has established numbers of guidelines, also aid memoirs, information sheets, general documents on strategies and plan, as well as developing the training materials and also conducting the workshop, training program, and site visits activity. And I would like also to inform you that in 2013, WHO has included the whole blood, red blood cell, platelets, and fresh frozen plasma into the WHO model list of essential medicines. And again, in 2018, through the International Conference of Drug Regulatory Authorities, this conference called to strengthen the hemovigilance system to monitor the safety of blood donation and blood transfusions. So in this slide, I would like to give you an example of WHO activity. So to respond the need of member states to improve the quality of plasma and also to go to the fractionation program, some document already been established, starting from the information sheets on plasma contract fractionation program, also on the ensuring the quality and safety of plasma-derived medicinal products, and also another guidance document, such as the guidelines to assist the country on the technical aspect and infrastructure requirement for development of fractionation program. And then another document, for example, is also the recommendation on how to produce, control, and regulation of human plasma for fractionation. So another example, because of those documents and when the country implement these documents, some achievement has already been in place. So this is the evidence. For example, the plasmapheresis is more actively campaigned. GMP, or good manufacturing practice, is more implemented by blood establishments. And in the last few years, Thailand has established local plasma fractionation plan, and more low to medium income countries are aware of contract plasma fractionation program. And as mentioned before, that WHO also has conducted the pilot project. So we call it this project as a Achilles project. So the success of this project in South Africa is that the National Bioproduct Institute, that has roots in local blood transfusion, currently fractionate fresh frozen plasma from South Africa National Blood Services, Western Cape Blood Services, and also recently they fractionate the plasma from Namibian Blood Transfusion Services. And the Achilles project also conducted in Indonesia, with the success that currently around 20 big blood centers in Indonesia have been GMP certified, and the biopharma, a government biological product industry, is appointed to manage the plasma fractionation program. So progress to overcome challenges is happen in the countries that implement WHO resolutions and guidance documents. So they have made progress in providing safe blood and blood products. However, progress in establishing and strengthening national blood system has been slow in many countries. So WHO thought that there is still a need to push for implementation of WHO guidance at country level, particularly in low to medium income countries. So in response to WHA Resolution 2010, WHO has recently developed the action framework to advance universal access to safe, effective, and quality assured blood products for forthcoming years, 2020 to 2023. This document has been launched in February 2020, and this document aims as a strategic direction to global efforts to address present barriers to safe blood. The document also consists of goals and strategies how to cope with the challenges, and also can be used to build the partnership and fundraising. So the document proposes 6 strategic objectives to cope the challenges. One is the appropriately structured, well-coordinated, and sustainably resourced national blood system. Second strategic objective is appropriate national framework of regulatory control, functioning and efficiently managed blood service, effective implementation of patient blood management, effective surveillance, hemovigilance, and pharmacovigilance. And the last strategic objective is building the partnership, collaborations, and information exchange. So since last year, we already implement the action framework through 2 activities. One is to develop some important guidance that is still needed to guide the countries. So based on the strategic objective, actually we identified there are at least 8 guidance need to be developed. So last year in 2022, we able to develop the guidance on centralization of blood donation testing and processing, and also the guidance on increasing supply of PDMPs in low to medium income countries through fractionation of domestic plasma. And this year, we are happy to inform you that the policy brief for implementation of patient blood management has been published, as well as the education module on update clinical use of blood. And maybe we hope at the end of the year, the tools for stepwise implementation of hemovigilance system can also be published. And for the 2 years coming, we plan to develop the guidance on costing of blood services, guidance on blood supply preparedness system during emergency situation, and also guidance on quality assessment of blood products, associated substance, medical device, and IVDs. So this is the recent published document. So you can access this document through the web link that I provided in this slide, and the education module on clinical use of blood. So hopefully by end of this month, we can also circulate the web link to this document. So another action on of the action framework is to give the technical assistance to member states. So this technical assistance, of course, should be conducted not only by the WHO headquarters, but also by the WHO region and country office. So the form of this technical assistance are the webinars, training program, country assistance, and training program. However, due to the COVID-19 situation, unfortunately, the training program, country assistance, and training program face-to-face method not able to be conducted. So hopefully, if the COVID situation is getting better, then these other 3 activities can be conducted. So from last year until this year, there are some webinars that has already been conducted by WHO, and also, of course, WHO, not only the headquarters, but also WHO regional office and country office also conducting some webinar. And WHO also has involved in some webinars conducted by international stakeholders, for example, conducted by ISPT. And of course, we are so happy also that now ITF also conducting the global forum, and maybe in the next 2 weeks, we will also support the PIF webinar. So to close my presentation, I would like to say that WHO resolutions has already available, and this resolution urged member states for self-sufficiency of blood products. And numbers of WHO guidance documents are available to guide improvement of quality of blood products. Robust blood regulatory system and well-coordinated blood system need to be in place to overcome challenges. And as emphasized by our DDG, that partnership and collaboration with international and national stakeholders play key roles to assist countries to improve their blood system. Thank you for your attention.
Thank you very, very much, Dr. Yoon. Really congratulations. Within a few minutes, you have managed to give an outline of the work of the WHO of the years on a recurring global issue. Thank you very, very much indeed, and for your messages. I was impressed really by the action plans, strategic objectives, and the relevant guidance. And I was also very happy to hear about the stepwise development of hemovigilance program that you are having. Thank you very much indeed. So now we are going ahead with our program, and I'm really very, very happy to invite my great friend, Dr. Gilles Follea, Advisor, Training Department of the French Blood Establishment, who is going to give a presentation on driving continuous improvement and resilience for blood transfusion services, challenges, lessons learned, and best practices. Of course, Gilles is French, and he graduated as a medical doctor, then specialist in medical biology, and later he got his PhD thesis on donor medicine. He served for several years as the director of one of the 17 regional blood establishments of the French blood establishment, EFS, and in the year 2010, he took over as the first executive director of the European Blood Alliance up to 2015. Allow me to say that under his position in the EBA, Gilles wrote history. He retired from EBA, but still he is contributing as rapporteur in the International Consensus Conference on his very favorite issue, patient blood management. Currently, he pursues his activities as volunteer, as member of the French High Health Authority drafting group for the patient blood management recommendations, and vice chair of the ISBT, the International Society of Blood Transfusion, working party again on blood supply management. Gilles, you have the floor. Thank you.
Thank you, Madam Chair. I'm going to share my screen. Here it is. Do you see my slides on screen? Okay.
Yes, yes.
Thank you very much, Madam Chair, and thank you to the organizers, and congratulations for these excellent and impressive initiatives. I'm fully supporting, of course, and thank you for inviting me to participate in this initiative for the first global forum. To speak about improvement, resilience, challenges, lessons, and best practice for blood transfusion services. Here you have my disclosure. I selected 6 challenges correlating to among the 6 challenges presented by Dr. Yuyun. 3. One is governance, the second is supply, and the third is clinical practices. These challenges are correlating to 3 of the 6 strategic objectives presented by Dr. Yuyun. And of course, from a review of the literature and my senior experience, as reminded very kindly by Madam Chair, I selected a few topics. You are here, so we're going to select and to start with the first one, which is on the top of the WHO guidance and TIF guidance, the most important one to my eyes. It is the red blood cells and the blood supply. We have since a global meeting held by the Council of Europe and the Committee Transfusion of the Council of Europe, EDQM, the CDPTS. I was chair of the blood supply management group at this time, and it was important to remind, and everybody around the table agreed upon this, that the blood supply management is a process involving 5 successive steps, knowing the past red blood cell use, making a forecast for the next year, making a collection program to supply the inventories, then weekly balancing demand and supply, and then review and update the patient's RBC needs and their satisfaction. For us, it's very important to underline that implementing such a process is a key factor to reach self-sufficiency. At this time, the working group of the Council of Europe led a survey, and I just selected a few answers showing that blood supply management process is not so well implemented in many countries. So we got responses from 40 countries all over the world, and the question, are there nationally coordinated blood and plasma programs in your country? I mean, 15% said no. But if there are a nationally coordinated vein-to-vein integrated blood supply management process in your country, more than 1/3 say no. And then about balancing demand and supply, when you ask the question, do blood establishments and hospitals in your country share blood inventory and blood demand data, 1/4 say no. Analysis of blood inventory and blood demand data, 40% said no. And the process of regularly balancing the use, demand, and supply, the real heart of the process, more than 50% said no. My guess is that at this time, this has not really changed. So it's important to remind something which is a very basic background, but very important, that blood supply management should be managed as a patient-centered loop. So we start with the patient's needs, and it is most important for the patients needed frequent transfusion. Then you need collection. We have very classical ways to promote retained blood donors. We have blood processing, donation, and then the management of the blood component inventory on the blood establishment side, and then on the hospital side. And then after orders, issuing is there to meet the needs of the patients. I would like to emphasize that coordination between blood establishment and hospitals is often missing, and it is an important and essential key factor of success. So we can add at this time with patient blood management that this coordination should also involve patients needing a frequent transfusion. In reflecting about what is very important, I thought that, well, it's important to adapt the blood supply to ethnic minorities. First, I start with in developed countries. Here you have a very basic background known by most of the participants, of course. Patients needed frequent red blood cell transfusion require phenotype match and antigen negative red blood cells to prevent and manage alloimmunization. We have to always remind that hemolytic reactions could be fatal. To increase probability of phenotypic match, donors and recipients should share same ethnic background, and ethnic minority donors are required to provide adequate supply of antigen-negative red blood cells and can phenotypically match to recipients. I think that Jennifer McKean and other authors produced recently a very good meta-analysis of studies investigating the interventions to correct the underrepresentation of minority donors in the larger donor pool. And they reminded multiple barriers: higher deferral exclusion rates, for example, low hemoglobin. Anemia is very frequent in those populations. TTI risk, cultural specificity, religious beliefs, myths about blood donation, knowledge gaps, lack of trust between minorities and blood donation services. Also, there are currently 8 prospective studies. I selected 2, so sorry for the authors of the 6 others. And I would like to emphasize the New York experience and the Marseille experience. The points in common to adapt the blood supply to ethnic minorities in the US and in France was education in target communities, awareness of blood donation need, enduring partnerships, very important, and target increase in proportions of minority donors. This has been presented in a very didactic way in the European Blood Alliance MIMI report. MIMI is for missing minorities, published in 2013. In Marseille, because it came from a research unit based on anthropology and transfusion. They really looked for an anthropologic approach and to adapt their promotional and rhetorical messages based on their research. So they had culturally adapted recruitment messages, and they involved cultural mediators. This approach has been extended now and adapted to other minorities other than Comorian, the original one. What I would like to stress here is that in Marseille currently now, from this work, when they want to promote donation and recruit donors in Comorian community, they organize meeting in mosques, and with a systematic speaking order, the imam is speaking first, then representative of the young Muslim community, and then EFS could deliver its messages. In saying that, I would say and stress that Marseille is using or implementing practices very close to practices implemented in other countries. As an example, the northern region of Togo. And so I would like to underline that sharing experiences between both worlds, developing and developed world, could be very important for the future for the patients. Now, we are going to speak about demographic projection, speaking about the US. And in the US, you can see that they're expecting by 2060 a total population more than 400 million. And by 2051, the population aged more than 65 will outnumber the population less than 18, which will be another issue for blood supply. But then you can see that, well, the Black and African population will increase, and even 2% is a lot of million people. It will say the same for the Asian, and also we know for the Hispanic one. So I would like to say that, well, migrations are inducing demographic change everywhere in the world. So migration is defined by International Office of Migration as the movement of persons away from their place of usual residence, either across an international border or within a state. It could be for work, but also for conflict, violence, and climate change. It is growing. It is occurring, we saw it in the US, but also in Europe, and probably not all continents. And it already exists as a major issue in some low-income countries. We know that the biggest crisis of refugees now are in Syria and Afghanistan, but also in South Sudan, which is the biggest in Africa. It is the newest, the most recent state created in 2011. Civil war started in 2013 with persistent intercommunal violences. We are here having ethnic minorities as well. And 1/3 of the people were forced to leave their homes. And at present, we have more than 1.4 million refugees. I had to present this example because now we have the Red Cross, and especially the Swiss Red Cross, working every day in a very unsafe conditions, extremely difficult to settle blood transfusion services and now to improve blood transfusion for patients. They deserve deep acknowledgement. Now I would like to contribute to solve and to be peaceful about something that was the discussion between family replacement donors and voluntary non-routine donation. We now, all the scientific community is in agreement with the available evidence. First time FRD and VNRD carry similar high TT to AR risk. Repeat donors bring lower risk, whatever the origin, and VNRBD and FRD reflect different cultures. Where FRD culture is deeply rooted, we have to consider both VNRD and FRD equally needed for the first-time donations and support actions plans to particularly develop retention for both VNRD and FRD and avoid the term of conversion. We are not going to convert people with different culture. Two caveats in this field. Please don't target increased percentage of VNRD without consideration to the blood supply. And please don't target decreased percentage of FRD. Both targets are potential threats on blood supply for patients. But now, in the action framework, the WHO recognize this as important to improve donor retention. And such approach helps ensuring a safe and sufficient blood supply and gradual development on VNRD. An example is the one given by the program of Swiss Red Cross in South Sweden, but also in Malawi. Now, minimizing the blood wastage probably needs more efforts. The discount of whole blood donations, the last available, are reported by WHO. These are WHO reported data from 2011. And we can say that in this year, on around 100 million donations, 5 million were discarded, which is a big volume. Here today, we are speaking about 40% of this discard relating to date expiry, transportation, and storage. With the ISBT Blood Supply Management Working Party, we carried out a survey to explore, this wastage in hospitals and investigate mechanisms of wastage. And you can see that for red blood cells everywhere in America, Europe, and the rest of the world, although the median are quite low, the ranges show quite high levels, and efforts should be carried out again to reduce these high levels. With this group, we also carried out a second survey in low and medium income countries, and they show even higher levels of wastage. So you can, with these studies, we provided tools to investigate simply levels and mechanism of wastage important to take action. Now, PBM, everybody knows that there are 3 pillars. For WHO and myself, I am a fan of WHO. I think that there are 4 pillars because it is important to improve tolerance of anemia, but also to avoid unnecessary transfusion. And it is to implement the principles of wisely transfuse. Of course, as underlined by the WHO, the barriers to appropriate clinical use of blood transfusions are limited training and knowledge in transfusion medicine and the lack of awareness and training on PBM. And as presented by Dr. Yu Yun, a lot of efforts and guidance are currently produced by WHO to overcome this barrier. An EBA survey published in 2018 showed the same. Even in Europe, we could identify a poor knowledge about PBM in 7 European teaching hospitals. As an example, with the Department of Training at EFS, Campus EFS, we set up a 3-day training entitled PBM-based transfusion counseling. It is dedicated to actors given counseling, transfusion counseling in the blood establishment, but also for clinicians and prescribers in the hospital side. And 3/4 of the trainers are from the hospitals. They are clinicians, prescribers. Most important factors of success is commitments of blood establishments and cooperation with hospitals. Everywhere where PBM programs are working, this cooperation is at work. We could quote, Pittsburgh, Ontario, England, Netherlands, Frankfurt, and Australia, of course, as among others. PBM could have some drawbacks sometimes, and it is a publication from Mark Hazel from the BEST group in 2016, showing that, of course, as expected, when you implement here in 7 countries and 13 blood establishment PBM programs, you observe a decrease in the distribution of red blood cells. But most important, you also observe an increase in the percentage of the O negative red blood cell distributed. The most likely hypothesis at this time is that while massive hemorrhage, massive bleeding needs the same amount of O neg red blood cells as before, there is a reduction of the other one. So this has to be observed, carefully watched, and anticipated for the future. Now I would like to end this presentation with a few words on postpartum hemorrhage. Well, WHO is really working on this since many years, stressing that PPH is the leading cause of maternal mortality in low-income countries and the primary cause of around 1 in 4 of all maternal deaths globally. And the majority of deaths from PPH occurring in the first 24 hours after birth could be avoided by appropriate management. So we all know that WHO has recommendations. These recommendations are regularly updated, and now we have a lot of other recommendations. The last one coming from NATA is presented as PBM measures. So I think that, well, improving the implementation of these recommendations would be very important and considered as a primary PBM measure in low-income countries. Here, last one, I would like to present a very specific work achieved in France. It is an organization of audits of the implementation of the national guidelines to manage and prevent the immediate postpartum hemorrhage. And you can see that, well, there are 4 main recommendations, and the level of implementation, the percentage of implementation is monitored every second year. And you can see in green, the hospitals implementing fully the recommendation, partly, and in red, not at all. And you can measure progress. You see here, plus 13% better in 2070s, and as compared to 13% 2 years before. And as a consequence, I mean, the mortality rate in France has decreased since now more than 10 years. It was more than 10 years ago, the first cause is now the third one. So I think that such a tool could be inspiring for WHO and TIF, not only for PPH in developing countries, but also for patients needing frequent transfusion with adapted tools to monitor the implementation of guidelines regarding, for example, sickle cell disease. As conclusions, I would like to stress again, I mean, the remarkable and excellent WHO action framework, which provides strong support for, very strong support for improvement, with all the guidance, meeting, workshop, etc., presented by Dr. Yu. But I would like to stress 3 items that for me would require more efforts again, or special focus. The first is on patient-based blood supply management with coordinations of all concerned stakeholders. And again, patients, when they require frequent transfusion, is a key success factor. Adaptation to demographic change involving blood type diversity is probably a major challenge for near future that should be addressed correctly with the tools existing right now. And further development of training on transfusion medicine and PBM of all involved actors is really critical for patients requiring frequent transfusions. Thank you very much for your attention.
Thank you very much, Gilles. Excellent, really excellent presentation. You have shown to all of us that patient blood management is an extraordinary tool for the optimization of blood and blood components in surgical and non-surgical settings, and how important and critical it is for the transfusion of the transfusion-dependent patients, like the thalassaemic patients. And you have really touched so many other important issues for transfusion medicine. Thank you very much indeed. Certainly it is multi-modular and multidisciplinary, and we will certainly need your help for further action. Thank you very much. And now we go ahead with our program, and I have the pleasure to invite a great friend, Professor Erika Wood, head of the Transfusion Research Unit at the Monash University and president of International Society of Blood Transfusion, who is going to give a presentation on safe blood and safe transfusions. Erika has so many titles, and she has been the protagonist of so many initiatives in transfusion medicine. I cannot restrict myself from saying that for hemovigilance too, because she was our immediately past president of the International Hemovigilance Network, and we would like to thank her because she has done so much work on this issue. But she's also a member of the WHO Expert Advisory Panel on Transfusion Medicine and the WHO Guideline Development Group on Anemia. She has been, as I mentioned already, now she's our president in the International Society of Blood Transfusion. You have the floor, please, Erika.
Thank you very much, Professor Politis, for that kind introduction. And it's really a pleasure to be here with everyone today. Let me just share my screen, and then I will bring up my slides. Now, I hope everyone can see my screen okay. Please let me know if there's
That's
any
fine.
problems.
That is okay. Yeah,
Thank you very much. So really, it's a wonderful privilege and pleasure to be here today with this international group of people, speakers, but also audience from around the world. And thank you for the opportunity to participate. In my day job, I'm a hospital hematologist as well as a researcher. And so I'm going to speak really from a clinical point of view. But I'm also, as Professor Politis mentioned, I'm also the president of the International Society of Blood Transfusion, which is my great privilege. And I will talk a little bit about the role of the International Society. So we are a scientific society founded in 1935, and we are in official relations with the WHO for a long time now. And our goal as an international professional society is to share knowledge to enhance transfusion practice. And we do this in a number of ways, including congresses, but we also have a number of working parties where scientists, doctors, nurses with specific interests can get together and share information to try to learn from each other and make sure that information about transfusion medicine is widely available. And one of our roles also is to advocate for the welfare of both blood donors and patients. If you're interested in finding out more about ISBT, then you can look us up on some of these platforms here, and we'd love to hear from you. So this slide really summarizes good clinical transfusion practice, and it makes it sound really obvious and easy. So transfusion should be getting the right blood to the right patient at the right time and for the right reason. Simple, huh? Well, as we all know, it's not that simple, and I will come back to this a number of times. As you have already heard, and I'm sure you will hear from the subsequent speakers, having blood available is a challenge in many, many countries. Having safe blood available and having the right blood that specifically meets this person's needs is often an extremely difficult challenge. Getting that blood to the right person at the right time involves a complex logistical pathway. And when that doesn't go right, occasionally it can cause serious problems, including complications of blood transfusion. And we'll talk a little bit more about that over the next few minutes. But all of that only has to happen if we have the right reason for the blood transfusion. And Dr. Follier was talking to us before about some changes in practice. And we've seen quite a lot of changes in reasons for blood transfusion, including a reduction in perioperative or surgical transfusions. And that's probably very appropriate. When I was a medical student, we used to transfuse a lot more people because they were anemic before surgery, before childbirth, after surgery, after childbirth. Many times, if we identify the cause of the anemia early and treat it, then people can avoid blood transfusion. Now, that clearly doesn't apply for people with hemoglobin disorders, such as thalassemia or sickle cell disease, or some types of bone marrow failure or blood cancers. Many people will be absolutely dependent on access to safe blood transfusion. So we need to think about the individual person and their needs. And we have to think, do we have the right reason for the blood transfusion? In many cases, with patient blood management, we will be able to avoid unnecessary blood transfusions. But for many people all around the world, they are absolutely dependent on a blood transfusion. And we need to make sure that all of these elements, the right blood, the right person, the right time, and the right reason are managed. So we've heard already about the importance of blood donors. And some of you will have known about World Blood Donor Day and been part of that every year. It's a wonderful celebration of the role of blood donors. And we want to encourage people to be volunteer blood donors because we know that this will create the safest possible blood donation for our patients. So then when we think about the role of blood transfusion in the hospital setting, we know that it is one of the most common medical interventions carried out in hospitals. And access to safe blood really does underpin many aspects of modern healthcare. In fact, it's almost unthinkable in many wealthy countries that blood supply limitations would be a problem. But that is not the case in many other countries. And in fact, adequate supplies of safe blood is so important that, as you can see, WHO has devoted a lot of resources to improving support for collection and testing of blood all around the world. And it was chosen as the theme of World Health Day, as you can see here with the nice logo, and a wonderful saying that safe blood starts with me. And I think that's true because we can think whether we could be a blood donor, and many of us could, or we could encourage other people to be a blood donor. But in a hospital setting, or as a doctor or a nurse taking care of patients, safe blood also does start with us because we have to make the right decisions with our patients. We have to make good prescribing decisions. We need to make sure that the process is safe. And we need to monitor people while they're having a transfusion and afterwards. So safe blood really does start with each of us at different parts of this process. And as Dr. Follier was saying before, we know that blood transfusion can save lives, either in an emergency setting, for example, a major bleeding from trauma or obstetric hemorrhage, or for people who are dependent on blood transfusions for their whole lives, including many people with hemoglobin conditions. But we also know that transfusions carry risks and they also carry costs. So we need to make sure that we are using this precious resource very wisely. So I want to give you an example from my own country, which is Australia. So every year, our National Blood Service is collecting about 1 million donations from the community every year. That's a huge investment in everybody's time, of course. and a great commitment on behalf of our blood donors. We are also needing to support that as a community, and the budget that our government provides is more than $1 billion every year just to have blood products available. Now, I know in many low and middle income countries, that's not the kind of budget that's available. That's itself an area where we need to do more work. And we've talked earlier today, Dr. Yuyun was talking about the importance of having a high profile of blood transfusion with government so that we will have national policies and proper support. But if we're spending this amount of money just to have blood products collected, tested, and available to our hospitals, we also need to think there must be enormous costs in hospitals for staff time, testing, administration, that we really don't understand very well. And we need much better information about how we are transfusing and some of the costs and complexities of this, because we want to make sure that our processes are safe and efficient. And if we are wasteful, and Dr. Folea was talking about reducing waste, these can come in many forms. We don't want to throw out blood because it expires on the shelf, but we also don't want to have to repeat processes because we're not working efficiently. We really need better data on what it costs to provide a safe and adequate blood supply. And this is just an example from Australia, but you can see that it's a huge investment on the part of the community. And this is only accounting for part of the data. So we all have a stewardship responsibility to use these products and these resources very wisely. And so in Australia, our government has articulated this stewardship responsibility and said to hospital management, to doctors and nurses and laboratory scientists preparing the blood, you are all involved in this stewardship responsibility. We share it, and we need to make sure that we take it seriously. So some people will be very familiar with this vein-to-vein approach, where we think of the donor at one end and the person who is the patient receiving a blood transfusion at the other. And there are many, many steps in collection, testing, and preparation of blood components. And then in the hospital setting, or in some cases, maybe a transfusion at home in some settings, many elements that need to be got right in this vein-to-vein approach to have safe blood. So we've talked already about some of the elements of blood safety, and I know also other speakers will talk a little bit about this. But just to summarize, I think there are some elements around having a safe product, national blood policy, having regulation to make sure that our processes are working well, robust quality frameworks in every aspect of our work, the low risk volunteer blood donor, and high quality manufacturing processes. And in the last 50 years, these have really transformed how blood has become a very high quality, much more reliable and standardized product where these are in place. Oops. But I want to turn now to think really a bit more in detail about safe practice, safe transfusion practice. So not just having a safe product, that's important, but then how we use these products. So we need to have careful, thoughtful clinical practice, which is evidence-based. And some people might be surprised to know that for one of the most common interventions in hospital practice, there are so many areas where we lack even basic information about how to make good transfusion decisions and to monitor their outcomes. So there's a lot of research opportunities here for young people, especially, who might be interested in a career in transfusion research. we need to make sure that our systems in the hospital and in the transfusion laboratory are very robust so that we have proper storage, for example, cold chain, we have proper labeling, we have proper inventory management, we have good logistical systems, for example. We need to know much more about the clinical outcomes of blood transfusion. So people might think, well, if someone's hemoglobin goes up, that is the outcome. Well, it's an outcome, but it's not the whole story. So really, we need to be much better at understanding, for example, how does the person feel after they have a blood transfusion? Are they less breathless? Do they have more energy? Can they walk upstairs? Can they go out and do their shopping? That kind of thing. And these quality of life aspects and patient-reported outcomes, what's important to patients or people having a blood transfusion, we have actually relatively little information about these kinds of outcomes from blood transfusion. And that's an area where our group is doing some research. And Professor Politis mentioned the importance of hemovigilance, and I will come back to that in a few minutes. So in the interest of time, I'm not going to go over all the ways that we work to ensure blood safety, but just to summarize here, through national blood policy regulation and accreditation of laboratories and clinical settings, by having low-risk volunteer blood donors, by many aspects of quality systems in our blood centers and our hospital laboratories, and then by improving our clinical practice through education and training of our staff so that they know what to do and when to do it. Informed consent, discussions with patients so that people understand why a transfusion is being recommended, what to expect, and what to do if they think they are having a side effect. I've mentioned the importance of evidence-based clinical guidelines and how much work we have to do there. And I'll come back to hemovigilance. But I wanted to emphasize that really there is a need for high quality research in just about every aspect of product safety and clinical practice transfusion safety. And I wanted to pay a special mention to pick up on this concept of governance that was mentioned by previous speakers. And I like this painting here, which is meant to be of King Arthur and the Round Table, but the idea that everybody is involved in making sure that we have good governance for blood transfusion. And so governance really can be considered the system by which an organization is controlled and operates and how people are responsible. And so in transfusion medicine, we've spent a lot of effort making sure appropriately that the product is safe, but we need to put a lot more effort into the way we practice to make sure that we've got these policies and procedures and structures in place for our clinical practice, that we've properly identified the clinical risks, and that we have mechanisms for recognizing hazards and then reporting and taking action when adverse events occur. And the way we do this in hospitals is by having a hospital transfusion committee that takes on this responsibility for oversight. In some situations, that's called a patient blood management committee, or they may have a joint role. And here is just an example of clinical governance from Melbourne, where I'm from our health department, Ministry of Health, that explains why governance is so central to high quality healthcare, including in our situation or our example, blood transfusion. So we've heard already about patient blood management from the previous speakers. And I thought maybe it would be helpful just to have a revision of the definition here. And the definition that ISBT uses is that patient blood management is an evidence-based, multidisciplinary approach aimed at optimizing the care of patients who might need a transfusion. So it's not just a doctor saying something, this is the decision, this is the recommendation. It also involves other people, nurses, for example, and optimizing the care of people who might need a transfusion, because we might be able to manage with some other approach. And it puts the patient at the heart of decisions made around blood transfusion, including appropriate use of blood and blood components and the timely use of alternatives where these are available. Some of the elements you already heard from Dr. Folea, so I won't repeat these here. But I wanted to emphasize that really patient blood management is considered an international initiative in best practice for transfusion medicine, and ISBT is a strong supporter of PBM. And sometimes patient blood management is presented like this in a 3 pillars model. And it was really a model that was designed or described patient blood management in the surgical setting. Pre-operative, operative, post-operative, for example, as you can see here down the side. And these aspects of optimizing the patient's own blood supplies, for example, prevention of anemia, minimizing blood loss, and improving tolerance of low blood counts. These are all important things in the surgical setting or perioperative setting, but they're not limited to that setting. And that's something that I really want to emphasize. So the way I like to think about transfusion decision-making is a transfusion needed or likely to be needed for this person, not just the average person or the average person with thalassemia or the average person having a hip replacement, but what about this person and what their needs are, but also what their values and preferences are. How can we incorporate these along with their symptoms and along with their laboratory results and along with their functional status, including their exercise tolerance, all that kind of thing. And that we would put all of these together in our pre-transfusion considerations and making it so that we can make a decision about if a person needs a transfusion, what type should it be, and how can we make sure that they get what's right for them, so that we can select the appropriate product, administer it and monitor closely, and watch out for adverse events. And then, as I mentioned, to evaluate the outcome of blood transfusion. Did a person feel better? Did they have improved function? And also to prevent, wherever possible, both short-term and long-term complications. These are just an example of some patient blood management guidelines that we've developed in Australia, and they're very helpful as far as they go. But one thing I wanted to say is that in most of these guidelines, in fact, it was not possible to make very many hard recommendations because the evidence base was so weak. So these are in the process of being updated now, and I look forward to a better quality of evidence that will be allow us to make some more robust recommendations. But hemoglobin disorders is one area that are covered in this medical module, and in fact were very, very weak in many aspects of the evidence base. And a couple of years ago, ISBT and some of the people on this symposium today were part of an international consensus conference on patient blood management, looking at red blood cell transfusions. And you can see here this nice way of presenting the levels of evidence around this question of red blood cell transfusion thresholds. And you can see here that only in 2 areas were there pretty strong evidence bases where we could make a strong recommendation about what to do in terms of a transfusion threshold for red cells. But in nearly all of these other areas, the evidence base was very weak, including in hematology and oncology, where further research is needed. So coming now to hemovigilance. So The International Hemovigilance Network defines hemovigilance as a set of surveillance procedures covering the whole transfusion chain, intended to collect and assess information on unexpected or undesirable effects resulting from blood transfusion and to prevent their occurrence or their recurrence. And some of the types of transfusion-related adverse events we've already mentioned today, and I won't go through these in detail, but really just to think that it's helpful to have some classification, infectious or non-infectious, for example, a way to think about adverse reactions. But as I'm going to show you on the next couple of slides, many of the serious complications of blood transfusion are not related to any inherent biological problem. They're procedural problems or clerical problems or administrative problems because we fail to identify the patient properly when we're collecting a pre-transfusion sample, or we mistakenly give it to someone for whom it was not intended. This is obviously a very serious situation when it occurs, even if no harm occurs to the patient. So, for example, if we give someone the wrong blood component, but it still was safe for them to receive it, then they may not suffer an adverse event, but it's still not the blood component that we had intended. And we know that near-miss events are much more common than incidents that go all the way to completion. So we can learn a lot from these types of events. And as was mentioned before, blood wastage is a type of adverse event because these products are precious. And we need to consider transfusion-related risks in the context in which they're occurring, in the clinical context, for example, maybe a life-saving transfusion versus a more elective transfusion, what type of component we're talking about, and of course, to balance the transfusion-related risks against risks of not receiving a transfusion when one is needed. So I'll finish with a few slides from a well-established hemovigilance system called Serious Hazards of Transfusion, or SHOT, which is the UK Serious Hazards of Transfusion National Hemovigilance Program. And you can see here on the right this figure, which is taken from their most recent annual report. And in the top section, there are a number of biological complications, some of which are very common, such as febrile reactions, but many of which are rare. And then at the bottom, you can see that these adverse events are things that occurred because basically of human error, including a large number of incorrect blood components being transfused. So we need to do better on this. And SHOT provides an annual chapter on hemoglobin disorders, and you can see here some of the types of reactions, including people whose transfusions did not meet their particular needs or where they suffered some kind of transfusion reaction. In the interest of time, I'm not going to go through all of these because time is short, but I'd really encourage people to have a look at this annual report because it's very illuminating. Now, of course, many safe transfusions are given every day, all days of the year, but we want to avoid complications like these occurring because they can be very serious for the patients, and occasionally they can be life-threatening or even fatal. So we need to know that these things can exist and take measures to prevent them. So how is it that we could possibly give wrong blood to a person? The person knows who they are. We know what we're intending to do. Well, one of the things, as I mentioned before, is that the process is very complex. So here is an example of one process map from a study that we conducted a few years ago when we were looking at trying to understand the hospital costs of supporting people with hemoglobin disorders, in this case, thalassemia major. And we mapped out every single process involved in the clinical and laboratory steps of giving a blood transfusion to someone in our hospital. And this is one process, but there were 31 processes, and they all had to line up or intersect with each other. And there was more than 600 individual activities involved in delivering a regular outpatient red cell transfusion to someone with thalassemia major. And the reason I put this example in is that it maybe helps us to think about the risk of the weak link in the chain. Only one thing has to go wrong, if it's an important thing, for that chain to break and for things to end badly. And so we have to get this right all of the time. So people often say, well, how can I, as a patient, be more involved in transfusion safety? Well, when people are asking you for your name and date of birth and other information so that we can check we're collecting the sample from the right person or that we're giving the blood to the right person, that's an active step that you can take to make this safety chain safer and more robust. There are many other examples of how patients and families can be more involved, and maybe we could talk about some of those in the question time. So just to finish, SHOT provides a number of key messages in their hemovigilance report every year. And I wanted to point out this third one here, which says patients should be involved in every decision to transfuse and fully informed of the risks and benefits. So even for people who are on long-term transfusion support, each time there needs to be a discussion about how the person is doing, what we're hoping to achieve today, and how the person can contribute to the safe transfusion process. So this is my last slide. I want to use this example of the lion who is sleeping with his eyes open. In hemovigilance, we often use this example because the lion is vigilant for risks. And that's how we like to think we have to be constantly vigilant for safe transfusion. And I'd just like to acknowledge the many people and organisations, including my own hospital and research group, whose work I've mentioned today. So thank you very much for your attention.
Thank you very much, Professor Wood. Really excellent presentation, very clear messages, and a very comprehensive presentation on things that everybody really cares about. And thank you for reminding us the basic principles, which are the most important ones as regards the good transfusion practices and evidence-based clinical practice. Thank you very much indeed. I'm sure that you will have many questions to answer back. And I hope that with TIFF you will have the opportunity and the time, rather the time than the opportunity, because you may not have that many opportunities to cooperate further. Thank you very much indeed. So we'll go ahead now with the last speaker of this global forum. And I have the privilege really to invite Dr. Androula Eleftheriou, who actually, oh, I'm sorry, yes, I have, I beg your pardon. I'm sorry, I have really missed, not missed, but I have mistaken. I would like to invite Dr. Alan Kitchen, who would like to give a presentation on blood availability, protecting the blood supply during infectious disease outbreaks, and guidance for national blood services. Dr. Alan Kitchen has been an independent consultant in blood safety and infectious disease screening since leaving the, as he says, the English blood service. However, he has never left, I think. But initially he was trained in transfusion science, and he held a PhD in virology from the Academic Department of Medicine at the Royal Free Hospital, University in London. And currently, Dr. Kitchen is the secretary of the UK Standing Advisory Committee for Transfusion-Transmitted Infections, a long-standing member of the WHO Expert Advisory Panel for Transfusion Medicine, and a member of the WHO Blood Regulatory Availability and Safety Advisory Group. Alan, you have the floor. Thank you very much.
Thank you very much. Screen. I hope that's now clear to everyone.
It is okay. Go ahead, please.
Okay. So thank you very much. Thank you, Konstantina, and thank you to the organizer, to TIFF, for asking me to speak on this subject. So continuing the theme of availability, one of the issues, and it is just one issue which can affect availability, is that of infectious disease. So I've been asked to talk about the WHO document, but I want to try and move beyond just that. And this presentation really has two threads, but they are interlinked. So first of all, an overview of the WHO document, the basis for the structure which is of the presentation. But also I want to include sort of trying to think about the issue of emerging threats as we go through this, and trying to make it, rather than just a bit of a dry thing, trying to make it sort of a bit of life and a bit real. So just to set the scene really, blood services must and do understand that there'll always be infectious threats. And these threats come from different sources and for different reasons. So we have a situation where existing infectious agents change in incidence. If you get increasing incidence of infection, then that can have an impact on blood availability. We have the situation with known infectious agents appearing in areas where they were not previously present. Now, an interesting one here, because thinking of COP26 at the moment and climate change, whatever people's individual views are, the truth is that if you look at mosquitoes alone, then mosquitoes are moving further north. So technically that means the risk of some mosquito transmitted infections moves with them. So, things change all the time. And of course, we get the situation which we have recently experienced with that of new infectious agents appearing. So there will always be infectious threats. They're not all necessarily turn out to be a long-term threat, but they are things which we need to consider when we think about the blood supply. And the point here really is that blood services need to be aware of these threats and the potential, at least, impact. And that impact could be transmission of infection, which is one. And the other one, which is sometimes forgotten about, is that of insufficient supplies of blood and components. Lack of donors springs to mind for most people. But of course, if you're losing donors, you may also be losing staff as well. So there are a number of things to consider as far as this is concerned. That's it. So, oh, sorry, I missed the slide. That's it. And I think as a general way of looking at things and just looking at a very, very general picture, one of the most important things is that blood services must have the ability to be able to respond. Okay? And that includes a number of things, and I'm sure there are other things as well, but importantly, expertise, having expertise either in-house or available externally. Information, and as you'll see later on, information is really quite critical to be able to make the appropriate responses and formulate the appropriate plans when you do face emerging infectious threats. Resources to be able to respond, support, and another important thing is an agreed acceptable level of risk. Now, that may sound a very strange thing to say, but the truth is that every transfusion has a level of risk. The aim of all blood services is to ensure that the risk is as small as possible, but I think most people would accept the fact there is no such thing as zero risk. So it's always trying to be a process to minimize risk, but there comes a time when there has to be a balance, and the risk level is sort of the key to that balance. Now, of course, when you have threats, the response required may vary, and it may be a no action required, and often is. Thank you very much. We've looked at it, we've assessed it, and there is no additional action required. In other cases, there may be a significant change to practice and potential for significant loss of components. And of course, every individual event, although it appears to be the same, may require a different response. I think that's really important. You can't characterize infectious threats as a single group. They are all individual, and of course individual to each country as well. So The development purpose of the document, I think it's important to bear this in mind, and this sort of follows on from what Yuyun was saying. This is a new WHO document published in 2019, so in advance of the current pandemic, but quite timely actually. And it was a response to requests from countries for advice on how to best to respond to emerging infectious threats. Now, some people may say, well, why? Well, because there have been a number of threats over the years. They haven't been global threats in the same way as the current pandemic, but they have been quite significant threats in terms of how blood services need to consider. The purpose of the document really is to assist blood services. It doesn't set it out in black and white in that sense. It's to try to help to identify threats and appropriate responses, and very importantly, to develop preparedness systems. And I think that's another important thing to remember, is be prepared. Now, of course, many countries, those with well-developed national blood services and healthcare systems, don't need such assistance. That's fine. But of course, there are many countries which do. And those countries may have no organized national blood service, and very often political and financial support is not forthcoming. National systems for monitoring of infectious disease outbreaks don't exist or are not effective. And in those cases, such documents, although many people may think they state the obvious, and to a degree they do state the obvious, but they can assist blood systems in advocacy. And that's what's really important, to obtain support and resources needed. So these documents really do, although they are documents and they don't give you everything, but they really are important to help support advocacy to get the required support and resources from governments. And just to say, this particular document, if you can see from the list of people who have reviewed it, it has gone around the world. So it has taken a fairly global flavour in looking at the document and trying to ensure that it actually does provide, a broad set of guidelines which blood services around the world could follow if they need to. So let's think about some basics. As I said, blood services are always potentially at risk of emerging infectious threats. It doesn't matter where you are in the world, there is always a risk of an emerging infectious threat. So there is the need to think about things, be prepared. But of course, the point is that you need to ensure both safety and sufficiency. And of course, like many things, there is a bit of a balance there. One of the fundamental issues is to be able to identify risk and determine how much risk is acceptable. And as I said, it really is important that there is an understanding of that risk exists, but it really is how to decide the level at which you would accept you can do things, and what measures you need to put in place to get to that level. Risk assessment needs information. Again, it's so often through this, it's about information. It's about people having good quality, reliable information. Obviously, the nature and degree of risk depends upon the infectious agent. There are infectious agents which are transmitted but have no known pathological effect. They have no associated disease process. And of course, each country will have its own needs and its own acceptability of risk. So every threat needs assessment. The responses may be very different in each case and from country to country. So how one country may respond to a specific threat may be quite different to another country. And maybe an example there I can give is that in some countries, travel and donors who travel, there is a risk because although a disease may not be endemic in their home country, they may have traveled to a country where there is a particular infectious disease. And let's just say malaria as an example. In those countries, they may have to say to travellers need to be deferred for a certain period before they can be allowed to donate, or they may require malaria screening. Other countries may take the approach that that threat is such that they actually do not want to deal with it, so that anyone who travels to a malarious area can no longer donate. So, the same threat, if you like, but potentially very different responses. And understandably, because again, different countries will have different levels at which they want to accept risk. So key aspects of responding. And I think the first three are really important. Early awareness of the existence of a potential threat, clear understanding of the implications of the threat, accurate and reliable information on the threat. Now, I guess that the current coronavirus pandemic is something which is sort of jumps to people's minds. And I've used that at the end, and we can sort of talk through that a little bit to try to look at some of these elements. But clearly, very early on in a pandemic or any other developing threat, awareness is important. Understanding the implications, which really is about having accurate and reliable information on the threat, which means a bit of understanding about the infectious agent and having some idea of what sort of threat is it going to pose, and how is it going to affect recipients of transfusions. Identification of possible actions to respond to the threat is important. What can you do? And again, that may depend upon whether you're considering sufficiency or safety, and the actions can be different, or both, obviously. Effective and accurate risk assessment to determine the most appropriate and proportionate action. I think proportionate action is really important, again, depending upon the level of risk that's acceptable. Communication is always important, and one of the important threads in the WHO document is to make sure people understand. And I think one of my particular bugbears, if you like, about the current coronavirus situation is that some of the communication about it has been very, very poor, and people panic simply because of lack of clear communication and therefore lack of understanding. So communication really important. Timely implementation of actions, always to try to get ahead of the game. So you're trying to respond before you have to react. And of course, situations change. So always regular reassessment to determine if, when and how the situation has changed. And in some cases, threats may disappear again. And I guess a good example of that, as far as blood safety is concerned, is Zika. And, Zika came up very, very quickly. It caused problems. It caused worry and concern. Blood services globally, or most of them, had to make some sort of response. And now, as the Zika situation has settled, very, very much settled, then a number of countries are now switching off or sort of pedaling back on some of the actions that they took during the sort of the height of the Zika epidemic. So it's not a single process. It doesn't sit still. Everything is moving. So as well as initial assessment, reassessment is always very, very important. Come on. Okay. So there are a number of key elements, and as I said earlier, information. Outbreak and epidemiological information, really critical. And I think this is one of those times where it really is important that global collaboration is there. And so often we've talked about sharing information, and in terms of infectious threats, it is really critical that there is global collaboration. Everybody needs to know what's going on. There needs to be active monitoring for the threats. The ability to assess monitoring reports, and this is where I said earlier about having expertise. There's no good having good monitoring reports if nobody really understands what they mean. So it really is, again, a question of having the ability to assess carefully. And back to sharing of information, always share information. It may not be relevant to you, but it may be relevant to someone else. And of course, the information we need has to be accurate and reliable. Now, of course, at the beginning of outbreaks, it may well be, and certainly in the case of the current outbreak of SARS-CoV-2, then information, it wasn't that it wasn't accurate and reliable, it was very, very little in nature. There wasn't a lot of information. We understood what a coronavirus was, we understood generally how coronaviruses behave, but this particular one, we didn't have that information. So information develops over time. So there has to be a good investigation of outbreaks. We have to understand the epidemiology, but again, it's a changing picture. Other information, of course, is it an endemic infectious agent or is it imported? Malaria, again, a good example. It's endemic in many countries in the world, but also it's imported into a sizable number of countries as well. So the threat is different. In an endemic country, you may choose to respond to malaria as far as the blood supply in one way, but in a non-endemic country, there are a number of other options which you may want to take. We need to understand how we define an area as affected. Again, using malaria as an example, even in endemic countries, there are parts of that country that may be unaffected by malaria. It may well be that there are parts of the country which are at higher altitude and don't have mosquitoes. It may well be that a country is affected by a threat during certain times of the year. During the rainy season, for example, malaria may develop at a higher level. So being clearer, is a whole country affected? Is a whole region affected, or is just part of the country affected? Really important. And again, just in the same way, information is also required to be able to turn around and say, okay, we now need to change things. The threat is now diminishing, or we've got procedures in place which actually cover it very effectively. We can now change what we do. So again, through it all, information is really important. We need to, but part of that information is understanding the threat. So we really do need to understand the biology, the underlying pathology, to be able to really understand the potential implications, and then understand, is this a safety issue, or is this a sufficiency issue, or is it both? And once you've got that clear, then it becomes easier to think, okay, so what possible actions can we take in this situation? So some of the information we need to understand, well, is it actually present in the bloodstream, and therefore potential for transmission via blood and components? Even if it is present, is it present in sufficient quantities to transmit? Every infectious agent has, if you like, a minimum infectious dose. And although transfusion of blood or components is a very large dose, if there isn't much there, it may still not be sufficient to transmit. And a good example of that, I know this is an example which is quite specific to certain parts of the world, is hepatitis E, where hepatitis E really has quite a large infectious dose. So there were a number of cases in countries in Europe, we've been looking at hepatitis E, where you had donations which had been found retrospectively to have been contained hepatitis E, but didn't transmit, simply because there wasn't insufficient present, even via transfusion. Does the infectious agent cause significant disease? Now, again, you have to consider here that if you've got an epidemic, a pandemic, then you have natural transmissions as well. So is it more likely that an individual, a recipient, actually was already infected, or have they got it via a hospital, a nosocomial transmission? And is it present in all or specific components? Again, taking certain examples, red cell preparations, if they have been, if they are essentially plasma-free, have much lower concentrations of any virus which may be present in the plasma. At the same time, an infectious agent like malaria is going to be present in red cells. So if you're looking at plasma components, a much lower risk. So understanding, the infectious agent is really important. And then that leads you on to say, okay, so what are the potential screening targets? Am I looking at the donor? Am I looking at the donation? Can I screen a donor first, or do I have to actually screen a donation? Because the donor has no clear risk that I can identify, whatever questions I ask. So it goes on, and it depends. So there are so many issues here which you need to consider. Does the infection result in immunity, or does it lead to persistent infection? Now, one of the problems as far as blood transfusion is concerned and screening blood for infectious diseases, a lot of the infectious diseases which we currently screen for and have been screening for many years all lead to persistent infection, which is why it is so important we screen. But of course, immunity can protect against infection or severe disease. And taking the example of the coronavirus, there has been a lot of work done to look at how effective is convalescent plasma from individuals recovered from coronavirus at helping to ameliorate or prevent disease in other infected individuals. Immunity can help reduce the risk of infectious donations entering the blood supply. If you've got a lot of immunity, then actually your donors may not, even though they've been exposed, may actually not have been infected. And of course, there is potential for passive immunity in recipient from components given. So it is a complex situation. And again, this is where understanding really helps you to figure out what you need to do. And then, of course, you come sort of through this and think about donor management. So if I've got donors who actually have got whatever infectious agent we're talking about, do they actually need to be referred for intervention? Is there a risk here that, you know, if we identify a donor who's infected, if we don't do something about it, they could suffer serious illness? So we have to consider the responsibility to donors. And then, of course, the most important question, certainly in terms of sufficiency, actually, once donors are, have recovered, can they be reinstated? And obviously, what we hope, by understanding the biology of the infection, is the answer is yes. If it's an acute infection, they recover, they can be reinstated. And it helps to ensure there is a stable donor base and minimize risks due to insufficiency. And of course, another step, once we understand the agent, is we have the ability to look at additional treatments such as pathogen activation or pathogen reduction, removal, a whole range of technologies, which may be a very effective methodology. So we don't need to do anything else but apply a certain technology or methodology. Maybe too early in some circumstances, but it's an option, and it's an option which is increasing in its usefulness as time goes by and as technology develops. So there are many things that we can do about it. It's just, again, as long as we understand what we're looking at, then we can figure out the best way of dealing with it. So what action can we take in these situations? Well, the first one, and probably one of the most important ones, is that no action needed. And very often we don't need action. Examples may be, and again, this is going to depend, vary from country to country, but parvovirus B19, very high rates of community-acquired infection. It is something which potentially can be transmitted through transfusion, but in most populations, that doesn't seem to occur. You've got high levels of immunity in the population, therefore quite a low risk of infected donations or of infection developing in recipients. In those situations, we don't really need to identify any specific risk in donors, even if we could. So there are a number of cases where emerging infectious threats are there, but on review, as long as the information is all there, it's decided that no action is needed at that time. We can try and identify at-risk donors, but of course it depends what defines at risk. And it is a key step in deciding what you're going to do, but you need to be able to identify those donors. Now, if it's travel or behavior or residency occupation, that could be relatively easy because you can ask the right questions. And as long as you get the honest answers, that gives you the information you need. But taking the coronavirus pandemic as an example, it's very hard to identify risk because it is a respiratory virus, it has spread globally. So actually asking donors the usual questions won't necessarily identify any specific which will help you to identify those who may have been exposed to the virus. We have to consider in any actions we take, what effect it's going to have. Is it going to have an effect on sufficiency or safety or both? Which one would be the most appropriate direction for action? There may be a choice. It may be that we're going to have to say safety comes first, so we're going to have to pull back because sufficiency is going to be affected because we have to do something here. Transmission of this particular threat would have serious consequences for recipients. Of course, there's also the potential impact if staff are affected. So even if we have a strategy which would actually maintain sufficiency, if we don't have sufficient staff available, then that can also impact if we can't collect donations because the collection teams are understaffed. So it is a complex situation. Lots of different factors all play their role. But when it comes down to more practical things, if we can identify a donor being at risk, they can be deferred. The question is, how long? And again, different views on this, but once people have recovered from an infection, then after a suitable period of time, in many cases, it's perfectly acceptable for the donor to carry on donating again. It was an acute infection. They have resolved it, and that is now the end of it. They now become, if you like, a safe donor. If we can't identify donors, or even if we can identify donors, the numbers involved will be so high, then we can consider laboratory screening. It may well be on all donations, it could be on selected donations. If you're looking at an infectious threat which is potentially associated with certain countries and therefore travel, then you only need to consider looking at those individuals who travel to those countries. But of course, one of the most important things, are assays available? Very early on in an infectious outbreak, it's likely that the assays won't be available, or they may not be available in a format usable by a blood service in that sort of mass screening situation. And of course, something which is important to me is confirmation of screen reactivity. So often people just do some basic screening, get some reactive results, and then consider that's the end of it. But confirmation is really important to understand what is really happening in my donors. You know, are they really infected, or is it non-specific reactivity? If necessary, another action, which is quite an easy action, is to stop collection in specific areas with high incidence. So permanent or temporary. So rainy season, it may well be we don't collect in that area because there's a higher incidence of malaria. So a very, very simple action, and it works in some countries. Inactivation.
You have 3 minutes, please.
Okay. Inactivation or removal of the infectious agent. Or another option is to importation of screened or otherwise low-risk blood and components. Some countries do consider importing screened products from other countries who either haven't faced the threat or have ways around it in which they can screen. Risk assessment. Risk assessments can, again, it requires information. So you can only carry out risk assessment if the information required is available, accurate, and complete. Early on, the required data may not be available. On occasions, action may need to precede a full risk assessment. So you have to act in advance because you can see the threat emerging, but there isn't sufficient information to do a full risk assessment. Where possible, the risk assessment should be national, should include the whole country, as well as other bodies involved. And it's not a static thing. The situation changes, risks change, and risk assessment should be reviewed all the time, and certainly should include staff. But of course, as I said before, every country, every blood service needs to be able to understand the acceptable level of risk for each situation. Communication, very important. People need to understand. Public confidence in the blood service, especially at a time when there is general public concern, is critical. Donors need to be reassured. HIV, donors were concerned at one stage that they would acquire HIV from donating. Communication, really important. Recipients need to be reassured that so they have confidence in the safety of the treatments they're receiving. And of course, education staff and other healthcare professionals is really important so they can understand the threats to the blood supply, the actions being taken, and then they can change their practice to support and to help that to be effective. So let's just look very, very briefly at current SARS-CoV. The appearance of novel respiratory virus is an interesting example of an emerging infectious threat. Okay, but is this safety or sufficiency? Okay, well, safety. Are respiratory viruses likely to be transmitted by blood and components? Well, viral RNA has been found to be present in blood samples. However, at this time, there is no evidence of transmission of SARS-CoV-2 via transfusion of blood or components, nor any other respiratory virus. So from a safety point of view, you could consider that may not be the major issue in this particular set of circumstances. Sufficiency then. Are donors likely to donate? Well, they will, hopefully. Infected and contact with infected individuals, well, if we can identify them, then we can defer until safe to donate. But of course, with this particular type of virus, where you become infectious prior to symptoms, it's much harder to actually ask any useful questions. Contact you'll know more about than infected, unless there's regular testing. You can have restrictions in place which may limit the ability or willingness of donors to donate, and that can cause problems with sufficiency if you're making it so hard for donors to come in. And of course, you have to have sufficient staff to maintain activities to maintain supply. But in this situation, it is more likely with the current situation that sufficiency has been more of an issue than safety. Okay. So how does the presence of the virus impact on collection activities and to support the sufficiency argument? Are there sufficient staff? And it's about the practicalities of the collection process. You know, how easy is it to donate in this sort of situation? And another thing to bear in mind, again, for SARS-CoV-2, how does immunity impact on blood services? Well, one of the ways it does impact was that suddenly there was interest in convalescent plasma, immune plasma, to be used for naturally infected individuals to help try to ameliorate infection, or certainly symptoms, in infected individuals with severe symptoms. And of course, you've then got to consider after vaccination programs in place, do we need to defer donors after receiving vaccines? So again, another level of complication and complexity added. And of course, and again, controversial, but herd immunity may or should eventually limit numbers of infected donors. Now, the herd immunity principle is perfectly sound. The question is, when you've got a respiratory virus like this, and you can take flu as a good example, how effective really is herd immunity? And that's really a bit of an unknown at this point in time. So just to summarize, the WHO guidance document was developed to provide assistance. Okay, it doesn't tell you, it's not an encyclopedia of everything you can do, but it provides assistance to develop structured responses to an infectious threat. It identifies key elements should be considered, but there are always local issues which need to be considered. And a key message is that of preparedness. Blood services need to be prepared for something that's likely to happen, and it has happened a number of times in recent years. And you can think of dengue, chikungunya, Zika, even Ebola in those areas of the world affected by it. But the balance between sufficiency and safety is something that must be considered in related to the actions plan. And again, it comes back to understanding and then determining the acceptable level of risk. So I hope I've done, I've taken you through a document, I've taken you through key elements and tried to sort of bring it to life to see how these things would be applied in a situation where infectious threats happen. But of course, blood services need to be prepared because there will always be infectious threats. It really is how we deal with them, how we respond, which is really critical. So thank you very much for listening.
Thank you very, very much, Dr. Kitchen. A really excellent presentation. You have covered, I think, everything, really. And I'm sure that many of the patients who are in line with this open forum will have many, many questions to you. And I wonder if we will have time really to answer these questions. Certainly, you have underlined the problem, the question mark rather, of the asymptomatic donor. And you have also stated that we shall always have some new infectious threats to threaten transfusion medicine. Thank you very much. We shall have to go ahead with the last speaker, who is Dr. Androula Eleftheriou, the Executive Director of Thalassemia International Federation, and who is going to give a presentation on blood safety and availability as viewed as transfusion-dependent patients. Androula has so many really... Well, okay, I will not say anything, just say that if Panos Englesos is the head, she is the heart of TIFF.
Thank you so much.
Go ahead.
Thank you very much. And all this that we have heard from the previous presenters, Dr. Polidis, dear moderator, allow me to say that they have been so educational for me as well, considering my background. Therefore, I anticipate that for all the participants, these presentations will really be a compass and extremely educational. What I am going to present really is not a scientific or a directive or a resolution of World Health Organization contents, but revelations, confessions, the confessions of the patients themselves as they view the extent and quality of services they receive with regards to transfusion therapy through the TIFF's work, the Thalassemia International Federation umbrella organization that today safeguards the rights of patients in the context of more than 206 members across more than 60 countries of the world, across the 6 regions, as these are defined by World Health Organization. And I'm really delighted and I feel very privileged to represent the Thalassemia International Federation and describe how the patients felt when they were asked about the quality of services they received with regards to blood transfusion therapy. So I'm going to very briefly touch on hemoglobin disorders and their impact, safety and availability for blood. What does that mean for patients with hemoglobin disorders? Some review of the international actions taken through the years and how TIFF wishes or expects to proceed and move forward in the context of a call to action. So disorders of the hemoglobin molecule of the red blood cells of the human blood, disorders which are hereditary genetic. They are caused by mutations of the gene controlling the amount of hemoglobin produced, as in the case of thalassemias, and they're called under the name quantitative abnormalities of hemoglobin molecule, or changes that cause mutations that cause changes in the structure of hemoglobin, that is qualitative abnormalities of hemoglobin, the most clinically significant of which is hemoglobin S. And according to the reduction or absence of particular chain that comprise the hemoglobin molecule, as we see on this slide, thalassemias are divided mainly into alpha thalassemia and beta thalassemia, respectively. Now, these are hematological severe diseases, both thalassemia and sickle cell disease, and in the absence of early accurate diagnosis and management, they result in multi-organ dysfunction and many medical complications, as you see on this slide. Therefore, it is essential to have an early diagnosis and appropriate management. And thalassemia refers to both beta thalassemia major, as we all know, that is transfusion dependent, but also in more recent years, and on account of research and results, we are looking at what we call non-transfusion dependent thalassemia syndromes that have been previously considered as of a milder phenotype, milder clinical outcome, but we now know, and there is evidence to show, that many of these patients with these disorders may also progress to severe disease and develop such medical complications that require early management, including early blood transfusion therapy. And evidence, knowledge and experience compiled mainly from successful programs initially of the countries of the Southern Mediterranean countries, and later with additional research and findings from other parts of the world integrated into international guidelines and recommendations, refer to some or demonstrate some elements that are needed for improved survival, improvement health and quality of life of these patients. And these include accurate and timely diagnosis, referral to trained and experienced healthcare professionals and treating centers who can in time refer to them to other medical disciplines necessary for their different medical complications in a structured and well-coordinated way, and including lifelong healthcare professional education, existence of disease-specific social care for these patients, and integration of research and innovation to continually improve the services, and through patient education to allow meaningful and active patient engagement at the decision-making level. All these elements contained within disease-specific national programs, registries, in the context of a healthcare system that is governed, or that is based on the principles of patient-centeredness and holistic coverage. This is how we feel many countries of the world who have applied such policies have improved the survival and the quality of life of the patients. Therefore, the two important components for effective control include prevention and clinical management, with all the necessary elements that, of course, in the interest of time and the focus of this workshop, we will not be going through. But prevention is part of effective control of this of the management of these disorders. Now, numbers, occurrence, and impact of hemoglobin disorders tell the story why they are of concern. And despite the absence of national and international registries, updated and upgraded epidemiological work, absence of new epidemiological, well-structured, designed epidemiological work in still large populations of the world, yet the numbers that are known to date, like 5 to 7% of the global population carrying an abnormal hemoglobinopathy gene, 100,000 and 300,000 annual affected births with beta thalassemia and sickle cell disease, respectively, giving huge numbers of patients with beta thalassemia and millions of sickle cell disease patients, the accuracy of which to date is unidentified. And there is a great need to develop national registries in order to better understand the occurrence and the impact of these diseases. But even with these numbers that we all consider as grossly underestimated, these disorders constitute a growing medical and health problem. They have huge medical, public health, social, and economic repercussions in more than 70 countries of the world that contribute to nearly 90% of the births and one of the first of the top 5 disorders that account for 25% of the birth defects. With regards to occurrence, despite the very early belief that these disorders, and in particular thalassemia, was occurring in countries around the Mediterranean Sea, hence the names thalassemia and Mediterranean anemia, the work of Thalassemia World Federation, but also other researchers later on have proved that these disorders were in fact more occurrent, as we see on this map, both sickle cell disease and thalassemia, in malaria endemic or previously endemic countries of the world. And there is a scientific link between the carrier rate and these disorders, giving advantage to the carriers over the lethal malaria disease. And of course, as we see on the left side red map, active population movement and migration for different reasons have literally introduced these disorders in almost every country across the world. But I need to stress the fact that despite the huge repercussions that we all know and the growing medical public health in so many countries, we are still not able to calculate and include hemoglobin disorders on the right path of disease burden because of the absence of registries, accurate data, micromapping in large populations in large countries, absence of carrier and prevalence rates, annual affected births, but very importantly, morbidity and mortality rates. We are not aware of these rates, so that the disease burden and the contribution of these diseases to the national and international burden can be identified. Some attempts have been made, more importantly and more particularly with sickle cell disease, because of the much greater number of patients with this disease, but they are still considered as neglected rare disease in many parts of the world, particularly low and low middle income countries, where sadly more than 80% of the global population is born and lives. Now, extensive molecular studies are seen on the right side of the slide, just to remind us that these disorders have a huge genetic background, giving an equally heterogeneous phenotype, clinical outcome, and therefore different management for these disorders is essential. So transfusion is the cornerstone, of course, of the management of these disorders, but it is not only used for beta thalassemia major, as we all know, because in more recent years, as I previously mentioned, the so-called non-transfusion dependent thalassemias, which are meant to be of a milder phenotype clinical outcome, have now proved that they can benefit considerably from regular or periodical transfusion. And as you see on the right side, there is evidence to demonstrate, published, that morbidities in non-transfusion dependent thalassemias are significantly decreased with initiation of transfusion. And of course, the value of transfusion to these disorders have been shown from the early years by early investigators in the 1970s, in that transfusion therapy increases survival because these were fatal childhood diseases. With transfusion, the survival increased, and in later years, research, iron chelation, multidisciplinary care, as well as effective prevention in a country have improved the survival and quality of life of patients. And I'm stressing the fact that management as well as prevention together can only increase the survival and quality of life of patients. Now, blood transfusion in patients with thalassemia, and we take the beta thalassemia major example, is not a simple blood transfusion. Effective transfusion for thalassemia means adequacy, and adequacy means enough blood to raise the hemoglobin, the pre-transfusion hemoglobin of patients, to that level that guidelines proposed by international experts through research and clinical evidence will combat the bone marrow hyperplasia, the organomegaly, the severe anemia, and will result to normal growth and physical attendance. So adequacy doesn't mean blood or any quantity of blood, but enough to keep pre-transfusion hemoglobin to recommended levels. And safety does not mean only blood donor screening. It's very important, of course, to extend to the maximum possible screening of donors and the blood in order to avoid to the minimum the transmission of transfusion-transmitted pathogens. But it requires appropriate processing, matched, filtered blood to avoid leukocyte-related adverse reactions. It requires regular antibody screening to avoid immunization and adverse reactions. And very importantly, appropriate storage and fresh blood, because our patients need red blood cells where the red blood cells are viable in the blood, that they have the hemoglobin that can transfer the iron to the organs and tissues, that this is the element they lack. Therefore, effective transfusion requires a lot of prerequisites for our patients. And Thalassemia International Federation, through its work across the countries and through the years, has made an attempt to capture the patients' and families' perspective through surveys compiled by patients, questionnaires, webinars, reports by healthcare professionals, or official reports from competent health authorities. And we have tried to cover all aspects of thalassemia, starting from the global epidemiology to the prevention, to the management, multidisciplinary care, social care, disease burden. We have described the value of patient engagement, and we have ended with the chapter 13 of unmet needs of patients. All together make up what we call Global Thalassemia Review 2021, which is a deliverable in the context of our work with World Health Organization between 2018 and 2021. We do understand that there may be omissions, there may be misinterpretation in trying to assess and grade the effectiveness of the countries or treating centers with regards to provision of services. But this is the information we have found published. This is the information, reliable information we have at TIFF. And this is, again, has been already said by the previous presenters, that we need exchange of information. We need synergies, and we need results to be published in order to have a better assessment of what is going on. What we had as an obligation to do was to capture our patients' perspective, the patients we represent for over 3 decades. Now, we cannot cover everything, but in the focus of blood and blood safety and availability, we have chosen some of the results that we have obtained through this global review on the chapter of patient, on the chapter of blood. So what we have seen is that we have studied the elements of adequacy, processing, and age of blood. And what we have seen, of course, was a great percentage of patients reporting postponement of blood transfusion therapy, with nearly 65% of regular postponement. We have seen patients reporting nearly 80% pre-transfusion hemoglobin less than 9 grams, with nearly 55% between 7 to 8, and with nearly 20% less than 7%, and a percentage of patients, of course, that could not remember their pre-transfusion hemoglobin in as an average through the years that the survey took place. With regards to processing, we have seen still use of whole blood, with 16.2, rarely, but with nearly 15% use of whole blood more than 5 times a year. Nearly 90% and more than 90% of our patients are not aware of the function and services of their transfusion centers in their country, or the processing of the blood, the protocol of the process of the blood that they receive. And nearly 70% reported as receiving unfiltered blood, with 66.5 at times and nearly 35% regularly unfiltered blood. Now, with regards to age of blood, 10% reported less than 14 days, only 10%, whereas the majority reported more than 14 days, between 14 to 20, and a small proportion, but still significant for their management, more than 20 days of age. The treating physician's perspective, a big percentage of them reported that hemoglobin disorders did not constitute a priority on the national health agenda of their country. There were no adoption of international guidelines and hence inconsistent care protocols. They felt they needed a robust central transfusion center with strong hemovigilance and patient blood management programs to be developed. They felt they need improved voluntary non-remunerated blood donation practices. And what was impressive was that more than 90% of the treating physicians stated that they felt insufficient support for the patients in terms of adequacy and processing of blood. There was an attempt to assess regionally the services received by the patients in the context of blood transfusion therapy. And what the parameters that we considered were only the postponement and the pre-transfusion hemoglobin. And despite the fact that in some of the regions that scored low, there are excellent transfusion centers, some of them even WHO collaborating centers, yet on an average, Europe and America scored the highest, and a lot of improvements appears to be necessary in Western Pacific, Eastern Mediterranean, and very importantly in the Southeast Asian region. Challenges were anticipated during the COVID-19. I'm sure that the participants and our patient community recognize the efforts that TIFF made during the pandemic. We very timely and very quickly produced guidelines and reliable information so that they're aware, but we also collected information and views of the patients on what were their concerns and challenges. All this slide shows is that they all face similar problems wherever they lived, whether in high development, in high income or low or medium income countries. Reduced access to transfusion centers, interruptions in blood transfusion, provision of whole blood in cases of low blood supplies in some countries, provision of unfiltered blood, and even halt of iron chelation, the second important cornerstone of management. But the challenges were magnified in the low and low-medium countries. The same challenges, with the exception of the whole blood provision, occurred also in the Western world, in the high development income countries, but all of them face shortages of blood and reduced access to transfusion centers. And the processing of blood was, on many occasions, temporarily or longer, had a negative impact. Just to mention and express a gratefulness to those international regional bodies that have contributed to blood safety and availability with information and guidance. And most importantly and mainly from the beginning, World Health Organization, through its many resolutions and executive board decisions related to blood, through the reports on blood supply and transfusion services that we have heard very elegantly, both from Alan Kitchen and other presenters. Very importantly and very useful weapon and compass for us is the World Health Organization Action Framework to advance universal access, protecting the blood supply and guidance on infectious disease outbreaks. And we are hoping soon that the global database on blood safety, which is using data from 2013 to 2014, will be updated and upgraded so that we can use it and improve more focused policies in the different countries. Of course, the European Commission and the revisiting of the European Directive on Blood, Cells and Tissue is very important for our European patients. And we are contributing to consultations and to the preparation of material, both in the World Health Organization, but also at the European level. The Council of Europe, of course, with its tremendous and invaluable contribution in producing the guide to the preparation, use, and quality assurance of blood components, and other medical orientated stakeholders like the International Society of Blood Transfusion that produced incredible work on the education and guidance of healthcare professionals. So TIFF has also contributed and has contributed since the establishment of TIFF back in 1986 with considerable focus on blood transfusion availability and safety, which is the one of the two cornerstones of its management through programs, educational, publications, integration and participation, contribution in consultative documents, collaborations with stakeholders, ISPD, ISH, EIHA, and partnerships. And we are in official partnerships apart from a World Health Organization since 1996 with the United Nations, ECOSOC, and with the European Commission and the Council of Europe. Last but not least, I wanted to conclude by saying this is a complicated and a complex slide, but all it shows is that assessing the elements that comprise effective control of these disorders, including prevention, management, multidisciplinary care, demonstrate, and this is the complete results of the Global Review 2021 in the last chapter, that there are many and complex and multiple unmet needs in more than 80% of the countries studied, and these are demonstrating, all these data and information are demonstrating the huge inequalities and the huge violation of the patient rights, which are not accepted by patients and by Thalassemia International Federation. Therefore, and we already know that more than 50% of the blood supply is still dependent on family replacement practices, and 42 of the blood donation units come from the high-income countries, which make up only 16% of the global population. That on its own indicates and demonstrates the need of increasing blood supplies in the countries which have the need, in the countries where more than 80% of our global population lives. So stringent adoption of World Health Organization's resolutions and utilization of the important and invaluable tools it produces to the world, patient advocacy, patient education, because all the information that the previous presenters have shown has to be to some extent translated to the language and the needs of our patients to understand in order to make and establish meaningful advocacy and networking to promote support transfusion services and recruitment. We would like to build diversity in the blood donor pool. And I think it's Dr. Fuller who spoke about the ethnic diversity going on and still increasing. The continuous medical education, not only of our patients, but of our specialists and healthcare professionals. And last but not least, the introduction of patient blood management and the innovation, the introduction and integration of innovation and research, that is programs and policies that will reduce the use or provide more appropriate use of blood, and innovation and research that may potentially decrease transfusion dependency of the patients. But very importantly, because we all know the value is to have universal health coverage. No country, however affluent, and high-income countries cannot support effectively chronic patients without universal health coverage, let alone in low and low-medium income countries where out-of-pocket causes dramatic consequences. And that is why Thalassemia is launching a new initiative, the establishment of the International Blood Alliance, Patients International Blood Alliance, for which you will have, of course, more concrete and comprehensive information later. And I'm just inviting all the prestigious speakers today and all of you and all the healthcare community involved in the care of these patients to join hands with the work and efforts of Thalassemia International Federation. Thank you very much for your for listening, but I need to thank and acknowledge the support of the TIF Board of Directors through the years, the confidence that they have given to the staff and to me personally, the TIF staff, each one working with passion and undivided commitment, the International Scientific Advisory Board, one of whom is Professor Costandina Bolidi through the decades, and every healthcare professional across countries. But last but not least, every patient and parent, organization and advocate who gives us the power, the empowerment and strength to fight for their rights. Thank you.
Thank you very much indeed. Really, I'm sure that you are all feeling, as I feel at this moment, listening to the excellent presentation by Dr. Androula Eleftheriou. With all these surveys and the conclusions that they reflect the reality and they show us the way to go forward and try to answer questions, complaints, doubts of the patients and their parents, how we can improve. And I'm sure that under the umbrella of the WHO and other stakeholders, we shall try to do our best and improve transfusion medicine for thalassemia. Now I have in my hand 25 questions, because we have come to... I have it here. I have it in hand. We have another session for questions and answers. And really, by reading all these questions, I have felt that for some of the questions, we need more time in order to write and answer back in writing. And we will do that. This is a promise we shall make.
Absolutely.
Absolutely, it's a promise. All right. Now, there are many questions which are really addressed to WHO and TIF. And I shall just pick up a few in order to understand what our patients are asking. Patients need to know how their blood is processed as per international recommendations. How does this information reaches the patients?
Professor Politi, I'm so sorry to interrupt. Can the panelists open their cameras so that we can have a panel discussion? Thank you. Thank you very much.
Okay. Another question. Are transfusion specialists trained for the transfusion needs of patients with beta thalassemia major? How can patients be aware if the transfusion specialists receive regular education and training on their needs? Are transfusion centers collaborating with treating physicians and decide on protocols for the transfusion therapy of patients? How can we persuade competent authorities to apply quality standards to transfusion centers? How can TIF and or WHO help countries have filtered blood? How competent authorities and transfusion doctors do not inform patients on the existence and value of the hemovigilance programs, and so on and so on. Really, I think that June, Erica, Gilles would like to give some answers at this moment, although I think after the presentation from Andrula, the same questions have been really set up during the survey. And we all need, as stakeholders, to try to see how we shall improve the work done under the auspices of the WHO with the help of the ISPT and all the other stakeholders. So please, who would like to give some first answers? Yun, please, you take the floor first, right? As a representative of the WHO, please. And then probably Erica, as a representative of the ISBT, president of the ISBT.
Thank you, Professor Politis. So,
please call me Dina. Okay.
Yeah, from WHO, I think maybe as I already explained that the role of WHO is to develop the guidance, the global guidance in the field of transfusion medicine, and also to give the country assistance. But of course, after we develop the document, the next step is to circulate or to disseminate the documents. So disseminating the document can be done through the serial webinar workshop, which not only conducted by WHO itself, but also maybe those seminar or those workshops can be conducted by our stakeholders. So for example, like in this occasion, it is also a good chance for WHO to disseminate our guidance document. And then for the country assistance, the WHO headquarters need collaboration with the WHO regional office and also country office, and of course also with the WHO collaborating centers. So for example, we have some collaborating centers for blood field, for example, in Shanghai, in Korea, in Singapore, in Germany, in UK, and in US. So this collaborating center also can conduct country assistance. And then another way is also WHO currently has established the advisory group for blood regulation, availability, and safety. So through this advisory group, WHO also can request whether the expert in this advisory group can also build the strategy to help the country to implement the WHO guidance or other documents. And then, of course, another way is also to collaborate with our stakeholders, for example, with ISBT to conduct the training maybe that is needed by the country, or maybe also when the country asks the assistance in the form of, for example, having guidance from neighboring country to implement the WHO guidance, then maybe we can also ask the expert in that country and also the collaborating center to help WHO. So I think that is from the point of view of WHO. Thank you.
Thank you very much, Yun. I think now probably Professor Erica Hood would like to add something on this.
Thank you. Thank you, Professor Politis. Yes, these are all great questions. And I think that it really, the types of questions really emphasize the need for the different parts of the healthcare system to be working together. So we need to make sure that doctors and nurses taking care of people with hemoglobin disorders are well educated about those things, but also about transfusion itself. And sometimes, and depending on the way the training systems are structured in different countries, people may train in very narrow areas of medicine or nursing or science. And this is very understandable, of course, but actually one of the things that I think would be very beneficial is working towards some cross-discipline training so that people who are interested in transfusion really get a better understanding of the needs of people with hemoglobin disorders so that they can provide better advice and provide better products and services to people who need them. So ISBT can help in the way that we provide education for health professionals around transfusion. We do this through our congresses and our online education activities. We also have an ISBT Academy, which is our educational arm, and professional groups, hospitals, blood services can apply for financial support from the ISBT Academy to help host educational and training activities. And obviously COVID has had an impact on some of this, but we would typically support dozens of activities a year to around the world to support people to provide educational and training resources, whether these are symposia or other types of workshops where people can really focus on what's important to them in their country. And this has been a very successful model. So people can find more about that on the ISBT website. I'll put the information in the chat.
If I may, I think I would like to make a question, or rather to set a request to Professor Erica Wood as a president of the ISBT, and say that about 2-3 years ago, I had a discussion with Paul Strangers about how can we improve things for thalassemia and patients with hemoglobin disorders in general through the ISBT. And Paul said, Dina, just submit a request and try to see if under the working group for the clinical management of patients, or a separate working group for thalassemia and hemoglobin disorders can be established. What do you think, Erica? Should we?
So there is
submit a
certainly
request
interest, as I mentioned in my...
forum today?
Yes, thank you, Professor Politis. There's certainly interest in that within the clinical working party. As I mentioned in my presentation, the engine room of the ISBT is our working parties in different areas. And the clinical working party is looking at an interest group within the working party to focus on different clinical settings, and hemoglobin disorders is one of those, which is under discussion presently. Thank you.
Okay, that's good news. Andrula?
Can I just ask a few questions that came directly now from the patients? So there is one. For developing countries with relatively fewer blood donors to provide for adequate blood for thalassemia, is it advisable for WHO or a World Transfusion Expert Panel to advise such countries to blood transfusion service not to implement permanent deferral of donors? That is an important, but I think the experts need to tell the patients why this cannot or can be made. They say not to implement permanent deferral of donors who had stayed in Europe or UK for more than 3 to 6 months. That's the question.
Yeah, thank you, Dr. Eleftheriou. I read that question. So actually, currently the WHO guidance on donor selection is updated. And actually in the draft of the updated document, we add some reason related to this one. So it is actually, this issue is related to the Creutzfeldt-Jakob disease. And in the draft document, we mentioned that living in UK for more than 6 months in the period of 1st January 1980 to 31st of December 1996. And also actually in this document, we add more information related to this issue. So I think Alan is really involved in updating this document. Maybe Alan can add some more information that already in the draft of the updated document. Alan, please.
I think that it's a complicated issue, and to me, it comes back down to risk and understanding risk, and countries deciding what level of risk they want to take. Now, the issue of variant CJD, the problem with it is there is a considered risk, and there is sufficient evidence of transmission, but the likelihood of it occurring is extremely low. A lot of countries, and understandably so, have taken what many may think the easy way out and just followed everybody else and deferred. Now you understand why, and part of it is because there is so limited information to support decision making in any other way. So it is complex, but from a UK point of view, UK plasma is now back in being used again, and it has now been considered that certainly after 1996, the risk of variant CJD had diminished dramatically. And I know some people are still talking about potential for a second wave, but that's a second issue. So the whole issue, I mean, where it be variant CJD or anything else, deferral has to come down to an understanding of risk. But the problem is, in certain cases like this, there is so little information. So you can see why countries would just copy what others have done and put a blanket deferral in. But if anything, if it helps, the UK have now moving back from that to a certain degree. So maybe other countries may follow on, and it is perfectly feasible, and I'm not saying do it, but it's feasible to now consider that potentially, though, if you're deferring donors because they've lived in the UK, if that living in the UK was after 96, then maybe it is time for some countries to review their policies and decide whether they now consider that the risk has diminished sufficiently.
Yes, but Dr. Kitchen, the countries outside, particularly in the developing part of the world, they follow what World Health Organization says. And I mean, it's not a country deciding on the exclusion criteria on its own. Probably they take the document. That's what we do in Cyprus as well. So if there is an updated and upgraded document on this, that would help the situation. Not to let the countries decide, because UK
Yes.
also.
Yes, you're right, but maybe but countries need to understand what they're doing, and countries, although you're absolutely right, and that's why WHO documents are so important, because they do help, but they are not meant to be someone else's. You're not, the intention is not that you just translate that document into a country's policy. It's supposed to there to help define policy, to inform.
I know it's the same.
I know.
It's the same like the European Union. You get the guidelines, but each country transposes into its national legislation.
Yes, but they're different because that's a legislative framework, whereas WHO doesn't legislate. But I take your point totally, but it's trying to get countries to understand themselves, not just to follow, but to try to make decisions. And I know it's very hard, and maybe it's a relevant one, but maybe it's not the best example to use. But there are, the new set of guidelines, when they finally come out, do take a more pragmatic approach, but they don't define. They're not there to define. They're there to guide. They are called guidelines, and the idea is to give countries information to help them define and decide what they want to do.
Thank you. The patients, another one on the donors. Thank you and congratulations from Pakistan. Is there a way to purchase blood from neighboring countries?
Yeah.
So this is the cross-border support that we're trying to do in Europe as well through this revisiting of the European directive. But,
that would be an ideal situation, but I think this is a very difficult task. It's a challenge. We have not, as you say, achieved it in European Union.
Yes.
Now, actually, I would like to tell you, in case you are not aware of the effort to formulate a strategic plan for emergency and contingency situations. And I'm a member of this working group, and we are going towards this direction. I hope that we will manage to do something for the international exchange of surplus blood. But for this, we need really to have a lot of regulations, adjustments, and a very, very revisited, perhaps, questionnaire for donor deferral and eligibility. And this is one of the questions actually very relevant to what we are talking. Do donors' questionnaires and exclusion criteria need to be revisited to decrease the excluded individuals and so on and so on? So these are challenges that have come from the patients to us, and I think that
but I think, Dina,
it's important to discuss it.
I'm just seeking the support of the panelists. Is there a way to purchase blood from neighboring countries? My opinion is that if a national competent authority feels, and of course Dr. Yunus and Alan Kitchen or Professor Erika for that matter, if a country feels secure to import, for example, from another country, again, is a decision of the national competent authority, isn't it? If a country, a competent authority feels sure, secure, and confident on the blood it receives from a neighboring country, I suppose there's nobody to stop them.
But can I just say one thing? And you have to differentiate emergency situations from total reliance, because total reliance, it moves away from a really important principle of a country developing its own healthcare system, including blood. So, in emergency situations, and as you can understand, but do you really want to support a situation where one country totally tries, its only source of blood would be purchasing from someone else? Because to me, that doesn't seem to be a good way forward for healthcare.
Absolutely. But there are countries at the moment, even in Europe, that, they import blood.
Dr. Andrew, so I would like to add also, because remember, one of the resolution mentioned that each member state should achieve self-sufficiency of blood for transfusion and also blood products for treatment. So I think from the WHO.
And that's what we want to promote.
Yeah. So in emergency situation, it's possible, but for the daily need, maybe.
Yes.
No.
That's what we would like to pursue.
We all agree with this, of course, statement, absolutely. And now I would like to read a hot, really question. Transfusion is supposed to be free of charge. We have to pay for blood filters and some tests, as well as travel expenses and loss of work. Please comment. Again, here.
WHO encourage country to collect the blood from voluntary non-remunerated donors. So of course, for blood itself, there is no cost, but we have to understand that there is a cost to process the blood to become safe for transfusion. So maybe, we never say purchase the blood, but maybe we say it, the recovery cost of blood. It is the cost to replace the processing fee.
And that is why that's why TIF very much promotes the Sustainable Development Goals of the United Nations #3, which is one of its universal health coverage. That principle is very important and substantial. Yes.
There is one question for Gilles. Is in general, how can a country monitor its blood supply levels at all times?
Thank you very much, Dina, for transferring this question. Well, as you know, by history, I was the first in France to really organize the blood supply management, and now it is organized at the national level, and exactly with the process I described. So I think for me, it's really a matter of governance, because at the time, I mean, the French Ministry of Health and EFS decided to have this kind of blood supply management. It was really a decision involving, let's say, governance, funding, and so on. And so what I really appreciate with WHO and TIF is that you are really supporting this way to have governance improved, funding improved, in order that more patients could have access to the transfusion. And I was very impressed by the very convincing presentation of Professor Eleftheriou. You are a fighter in favor of the rights of the patients. And I'm a fan. I'm really supporting you. And if I could help in some way, I would be very happy to do so, and particularly to help in implementing blood supply management. I could add that, well, it's not so complex. It's a matter of decision. And when the decision is made, I mean, implementing is quite a simple process, not really complex. So if I could help somewhere, I would be very happy. Thank you very much.
Thank you very much.
Thank you. I think that I feel, allow me to say, I feel that there is one question that has to be heard, at least. How and in what ways help in transfusion therapy can be provided to needy patients in refugee camps? Who monitor their health? Who wants to answer that or to discuss that question?
On occasions, TIF wants to go and see in migration camps how we can help, either with transfusion or with drugs. We have no way, and this is probably a desperate call from a patient in a migration camp.
Gilles?
Yes, well.
You have touched the migration problem.
Yes. was held to speak about that because in 2019, I've been requested by the Swiss Red Cross to evaluate their blood programs in 11 countries, all located in low-income countries. And that is the way that I quoted South Sudan. I could have quoted also Malawi, Kyrgyzstan, Togo, Honduras, and so on, you know. And I'm really admiring what they are doing, because you are staff working daily in countries where conditions are extremely difficult. I mean, South Sudan is, well, now it's reducing, but a bit earlier, there was a civil war, and I mean, the staff of SRC needed to be protected against violence, you know. But despite this, they are very successful, in my opinion, because they are really successful in implementing blood service and blood transfusion for patients. And as you could understand, there are a lot of refugees in South Sudan, and they are, of course, part of the patients. They are also working in Palestinian camps in Lebanon, for example. So they have a good experience of that. And I'm sure they are working in close connection with WHO. And this could be another connection with TIF as well. But for me, it is the best example I know, but I'm sure that there are others, many others, working again in extremely difficult conditions and achieving very good goals and meeting needs of more patients than before.
Thank you very much, Lil. There is one question for Dr. Kitchen. How can you ensure, although you have already mentioned it in your presentation, but still I think we better just discuss it again. How can we ensure sustainability of our donors pool during epidemic and serious infection outbreaks?
I think we
have already, yes, but still
covered. Yeah.
The patient would like to have an answer.
To be honest with you, I don't know whether you can answer it. Because it really depends on what you're talking about, and it depends on the outbreak. If you use coronavirus as an example, looking at published papers and reports and reviews, some countries have been clearly affected. Other countries haven't been so affected because overall demand has dropped, and it has left the only real users or recipients being the multi-transfused. A lot of the trauma cases, a lot of the electives have not been. So it is almost, I think, an unanswerable question. The way I would answer it, I guess, is to say preparedness, so that blood services are prepared as much as they can be for any emerging threats, and have the ability to assess very quickly whether it's likely to be a sufficiency issue or a safety issue. Now, so far, to be honest, most of the recent pandemics, epidemics, should I say, thinking back from 2010, have been more of safety than sufficiency. They have been the mosquito-borne infections, the rapid development, the rapid movement. You can see West Nile, chikungunya, Zika. So they have been more safety. So in most cases, not everywhere, in most cases, it's been more a question of ensuring that the appropriate questions are asked and the appropriate screening is performed, rather than a real risk of loss of significant numbers of donations. But it is very hard, and it's going to depend. Each outbreak is going to have to be assessed as it happens. If there's another respiratory virus outbreak which turns into a pandemic, then we could risk going through the same thing again. So maybe lessons learned this time would help. But you can't, if you've got a pandemic where the population at whole is affected, it is very, very hard to do anything to really try to maintain a donor base, because it will be eroded because people are becoming ill.
Yes, but Alan, there is in the UK, for example, and maybe Professor Wood can also add to this. Outside the infectious outbreak, there is a policy where you keep safety levels of blood. And I'm referring to the hemoglobinopathy, for example, the red blood cell. Yeah. And when your safety level falls, you're magnifying your efforts towards. So this is what these patients, some of the patients are asking, what's the mechanism of keeping a safety level at all times, let alone infectious outbreaks? Because you are very right, in some of the countries during COVID-19, the donors were so empowered to help the hemoglobinopathy, thalassemia patients, that it even increased in supply during COVID-19 in some of the countries. But keeping safety levels is probably a tool, and I'm sure Professor Erika can also comment on this. Keeping safety levels of blood at all times.
Well, thank you for the question, and Gilles, maybe Dr. Follet may be better placed than me, but I'll start. So I think there are a number of things. We all recognize that blood has a shelf life, and so it's important that we have awareness in the community about that, so that blood donors realize that blood donations are required all the year around. So a lot of work on community awareness is a very important investment. And then we have to make sure that our donor centers and mobile arrangements for blood collection can be managed under different circumstances, including often quite challenging times like we've experienced with the COVID pandemic. And then there are other aspects which are really about logistics, about inventory planning, inventory monitoring, moving blood around to make sure that it's there where it's needed, but also not going to be wasted by expiring where it's not going to be used. And this is where having a national blood service or a nationally coordinated blood service, even if it's not all managed by the same blood establishment or blood operator, can be very valuable, because you can increase not just the logistical power, but the sheer visibility of a national inventory. Sometimes in some countries where there's really good integration between the blood service and the hospitals, sometimes there's true visibility all the way to the hospital stocks in real time. And some countries have made excellent progress. The UK and New Zealand would be a couple of examples off the top of my head. But these are investments. Part of it is about, part of it is structural, and part of it is technology, to have the visibility in real time of inventory holdings. But maybe Dr. Follet would like to comment further. He's a more expert on this than I am.
Thank you very much, Erika. Yes, just as I said, I would just like to remind all the facts. It was in Europe at the occasion of the first SARS-CoV-1 pandemic. And at this time, the European Union, it was, I think, in 2009, something like this, the European Union was able to relax two donor selection criteria, just to absorb, the potential impact of the pandemic on blood donation. So we have to keep this in mind. Even a highly regulated continent like the European Union can be flexible sometimes to adapt the criteria to maintain the same level of safety, but have a protection of the blood supply first. The second is that, for me, this is really dealing with ethics and ethical conflicts. So, of course, I'm very supportive of the ISBT Code of Ethics. Well, I was one of the main writers around Peter Flanagan, and I think that we have to review it regularly, because it helps to answer such questions. Of course, ethical principles should be, we should comply with these principles for donors on one side and with patients, of course. And sometimes, like this, you could have conflict. Is it possible to collect donors in a region where hemoglobin levels are low? anemia prevalence is very high, and TTR prevalence is, and at the same time, we have to treat patients. And of course, like Dr. Kitchen presented, you have to really analyze this and integrate the code of ethics of ISBT to understand what is doable. But flexibility is not synonym of lesser criteria for quality and blood supply. So I think it's just opening the discussion and providing ways to reflect, to be adaptive in complying with rules for safety and supply. I try.
Thank you very much. Just, Dina, because there are many questions on the treatment of thalassemia, I just want to tell to the participants that this is not a webinar on drugs and on, because they're asking me whether they can purchase Reprosil and other drugs and how TIF can help. Of course, we can help, but this is the subject of another webinar that you will all know. So dear participants, when you're asking about disease questions and drugs, you will be answered. Each one you will get a response, but not in the context of this, because this is focused on blood. Sorry, I had to...
Okay, no, it's all right. I just wanted to say, following to what Gilles said, I think that another strategy which has been already applied and has been rather successful in some countries, European countries, is the strategy of elective transfusion in some patients, groups of patients. First of all, of course, for the emergency cases, and then for oncology cases in need of transfusion, as well as for multi-transfused patients. This is the case of Greece anyway. Particularly during the first wave of the pandemic, that we had estimated that we had a decrease in the blood collection by 22, even 31%. We followed this strategy, and it was quite acceptable by the society. But now that we have recovered, and through a campaign and communication with all various parts of people interested in this issue, with the professional associations, talking with hospital blood transfusion committees, patients associations, and so on and so on. The Ministry of Health has announced that we have stopped that process for the elective strategy of transfusion, and that everyone who is in need for blood transfusion has a right to have transfusion and clinical care. So, I mean, it depends, as Alan Kitchen said, that it depends on what is the epidemic, how important the situation is, and the risk assessment of every epidemic or pandemic. Now, I think that, do we have another one?
I think two, and we won't keep our panelists longer, but there is one from George Constantino, who,
oh, yes.
I'm revealing the name, and I shouldn't, but he's a patient expert, founding member of TIF. He has traveled all over the world, and he's a passionate supporter of the rights of patients across the world. He asks a simple question: what do you think the problems of adequate supply and low quality of blood is due to, finance or political will? Each one of us could answer this, but Dr. Yunan.
Thank you, Dr. Eleftheriou. So maybe I will share the experience of my country, because at the I come from Indonesia, is a developing country. So indeed, we have a difficulty period on improving the blood service in the country. So my feeling, the important thing is the political will from the government, because if the government really want to improve the blood system, actually the funding is there. they can mobilize the funding from other departments, for example. So for me, I think the political will is the most important thing. Thank you.
Fully agree, Dr. Yu. From our experience, that is the most important. Political commitment, yes. And the other final question from another patient expert from the USA, and I thank Maria, who's always with us at the webinars. She says, how about Afghanistan, Venezuela, and some of these countries that lack complete blood? How can we support these countries? Another passionate supporter of the rights of patients. We have no answer, really. Unless one of the panelists has the answer, that will solve the problem. Yes, okay.
I think it's time now rather to close the session.
Promising to all the patients that each and every
yes, they will receive their answers.
And we will, I'm sure our panelists are committed to help us answer the questions. Thank you so much.
Thank you so much. There are, of course, questions about thalassemia intermediate, about if one can catch hepatitis E sits next to another. All this will be answered, of course, with great respect. And we would like to thank, first of all the participants that they have been staying for nearly 3 hours. And many thanks to all of you speakers for your effort and your collaboration. And congratulations to TIFF for organizing this global forum, which is going to be the first, okay? Because we are going to have one, from what I understand, one every year, right?
Yeah, and even more.
And even more.
You know, just being in the end and thanking immensely the panelists for the great honor and World Health Organization in particular, but each and every one of you, the participants, patients who have been with us and are always with us, and they see compass and light in their difficult patient journey. Let me express my thanks to the board of directors again of TIFF and to you, Dina, because you have been thanking everyone and you have been reading what we've done in our lives. Well, we thank you very much.
No. After all, I have been spending half of my life as a clinician for thalassemia.
You have been
I had to do it
on a voluntary basis with TIFF. But believe me, dear panelists, I have not seen such a passionate person than Dina, traveling all over on a voluntary basis, and we need to thank you for this and for so many years.
It's my pleasure, and it was my duty to do that.
Staff, Dr. Michael Castignodis, who is here always hiding and being behind the scenes, but he's the medical advisor of TIFF. Michael, can you just
come here, and I would like to applaud.
Yes,
for you.
Yes. And
I'm just a listener.
Yeah, and we are very privileged to have the concluding remarks from Dr. Yun. All the burden on your shoulders, Dr. Yun.
Thank you, Dr. Eleftherio. So, dear colleagues, without realizing, we have arrived to the end of the event. And I think we all agree that we have had a fruitful global forum. So now I got the difficult task actually from TIFF to give the concluding remarks. So I think all speakers have shared knowledge and experience nicely, and also a lot of questions we received. So we have a really nice discussion. And from their presentation, as well as from discussion, we have learned and are hopefully more aware that the world, especially low to medium income countries, still face some challenges in achieving self-sufficiency of safe blood for transfusion, as well as blood products for treatment. And as mentioned in the presentation, the key challenges include weak blood regulatory framework, insufficient blood supply, deficiency in quality and safety of blood, as well as suboptimal practice in clinical use of blood, hemovigilance system, and patient blood management. Emergency situations such as COVID-19 pandemic over the last 2 years have contributed in the increase of challenges threatening the blood supply and having a direct impact on the life of patients in need of blood, and in particular, the thalassemia transfusion-dependent patients. Several World Health Assembly resolutions and many WHO and other international guidelines are available to assist countries to improve their respective blood system, including guidance on ensuring a safe blood supply during infectious disease outbreaks, as well as WHO interim guidance on how to maintain the blood supply during COVID-19 pandemic that was issued in early 2020. However, chronic challenges of blood services still exist in many low to medium income countries, mostly due to lack government support, manpower, and financial resources. The WHO action framework that has recently been developed offers 6 strategic objectives to overcome these challenges, which need to be supported not only by the WHO country and regional offices, but also by the government of the member state and also blood-related stakeholders. So Dr. Folia in this event has emphasized that patient-based blood supply management coordinated by all concerned stakeholders is a key success factor, and continuous education and training of all involved actors on blood transfusion medicine and patient blood management is also a critical for patients requiring frequent transfusion. Dr. Wood stated that patient safety is important and can be achieved not only by providing sufficient safe blood, but also by practicing safe transfusion, so that adverse events can be avoided. So I really like what Dr. Wood said, on the right blood to the right patient at the right time for the right reason. So decision to transfuse blood should be made very carefully. Dr. Kitchen in his presentation explained that infectious disease such as COVID-19 has indeed brought the challenge on safeguarding the blood supply. So therefore, blood services need to be prepared to deal with something that is likely to happen. And in developing the blood supply preparedness system, the balance between sufficiency and safety must be considered, and the acceptable level of risk need to be determined. Hemoglobin disorders is a growing health problem in 71% of 229 countries, and migration introduced these disorders into the population widely across the world. The disorders bring huge medical, public health, social, and economic impacts if not appropriately treated from early life. And transfusion is one of the 3 main arms of clinical management of these disorders. Therefore, from the point of view of patient expressed by Dr. Eleftherio, availability of safe blood supply is a critical issue. Clinical use of blood and again, patient blood management practices are considered as key factors to avoid unnecessary transfusion. So the blood that is already scarce can be used for patients who really need transfusion, such as the hemoglobin disorders patients. Dr. Eleftherio emphasized that transfusion-dependent patients are frequent users of blood services and their rights really need to be protected. Listening to the voice of patient is fundamental and should be encouraged to improve blood services. So I hope that this global forum will give a better understanding of the strategic vision and goals for blood safety and the protection of blood supply, especially in low-income settings. Moreover, this forum will hopefully help member states to identify possible mechanisms and strategies for the implementation of WHO's resolutions and action plans in the field of blood. Partnership with all blood-related stakeholders, including patient organizations, need to be maintained and improved, as we cannot work on our own to overcome many challenges that still exist. We hope that through this global forum, the awareness and sensitization of governments in acknowledging the many challenges in reaching sufficiency of safe blood transfusion practice, in listening to the patient's voice, and in involving them in decision-making processes is enhanced. I sincerely would like to thank TIFF for conducting this successful global forum, the International Society of Blood Transfusion for its continuous support in the field of blood transfusion education, all speakers for sharing with us their knowledge and experiences. To the global blood ecosystem, including bodies such as European Commission, the Council of Europe, the European Blood Alliance, the International Hemovigilance Network, the European Hematology Association, the American Society of Hematology, the European Center for Disease Prevention and Control, amongst others. We appreciate your contribution to policy improvement at national and regional levels and to the adoption of WHO guidelines on blood safety and availability. And last but not least, to our audience, thank you for your great attendance and active discussion. So I hope we will meet you all again in the next year's meeting of the Global Forum of TIF. So thank you. Have a nice weekend.
Thank you very much.
Thank you very much.
Thank you very much.